Hello everyone, I am Dr. Sanjeevani. I secured an All India rank of 91 in INI-CET May 2026. Currently, I am doing my residency in internal medicine at AIIMS Mangalpur. So today's session, we will be reviewing PrepLadder NEET Target Test 5 together. So let's dive in. The first question is, a 62-year-old male with a history of diabetes and hyperlipidemia presents for a routine follow-up. Despite lifestyle modifications and treatment with metformin, his lipid profile remains suboptimal. The physician decides to initiate a combination therapy with a statin along with a fibrate to improve his lipid profile further. Which of the following best explains the mechanism of action of the fibrate in this patient? So the keyword to understand is the last line. What is the mechanism of action of fibrates in this patient? First option, it inhibits HMG-CoA reductase. HMG-CoA reductase is actually inhibited by statins. It is not the mechanism of action of fibrates. So this can't be the answer. Activates peroxisome proliferator activator receptor alpha. Peroxisome proliferator activator receptor alpha activation is the main major mechanism of action of the fibrates. So this looks like the answer. Third one, it binds to the bile acids in the intestine so that the bile acids won't get absorbed and that it will reduce the cholesterol. This is the mechanism of action of BABAs, which are nothing but bile acid binding agents like cholestyramine and cholecystipol. So this can't be the answer for this. Fourth option, inhibits lipolysis in the adipose tissue. Even that is not the mechanism of action of fibrates. So the correct answer will be option 2. We'll go to the next one. A question from the PSM. Yeah. Sensitivity is the ability of the test to detect. Firstly, I just want to tell, this is actually a board way which we actually write. Something who is diseased, something who is not having disease, someone who get tested positive, someone who get tested negative, and we write A, B, C, D. This is how we actually learn. But I learned in a way that true negatives, true positives, false negatives, and false positives. Just like this. We don't have to remember A by C plus D, B by C plus D. It's just that, remember, sensitivity is all about true positive and specificity is like you'll have true negatives. And positive predictive value. The name itself is telling it is positive predictive value, which means in the numerator also, in the denominator also, you should have everything in the positive values. That means positive predictive value is true positives by true positives plus false positives. Whereas in negative predictive value, it is all negatives. So in the numerator also, in the denominator also, we should have all the negatives. So true negatives upon true negatives plus false negatives. This is about positive predictive value and negative predictive value. Now coming to sensitivity. For the sensitivity we can tell it like true positives upon if true positives plus. If we write again false positive, that will become positive predictive value. But we are discussing about sensitivity. So it can be true positive. So it will be false negatives. Next, whereas specificity. Specificity we can write like true negatives upon true negatives plus false positives. This is how we can actually remember sensitivity and specificity. So sensitivity is the one thing which will actually detect those individuals who have the disease. That means it will detect true positives out of all those who have got the disease. Whereas specificity, it will detect those who did not have a disease. That is what specificity is. Next, a question from the pharma. A 60-year-old male with a history of Parkinson's disease complains of pain after he underwent a laparoscopic inguinal hernia repair a few hours ago. Shortly after taking a medication for pain relief, he became agitated, started sweating, and physical examination revealed tachycardia, hyperreflexia, and myoclonus. Myoclonus is the keyword in this question. Which of the following drugs was most likely given to this patient? So, a clinical features which are very much fitting into serotonin syndrome, which means your body is having excess of serotonin. When will the excess of serotonin be present? Whenever it is not getting metabolized. That means if we are taking in combination of SSRIs plus MAO inhibitors and tricyclic antidepressants together, we will have so much of serotonin. In this, we do not have any option which is containing SSRIs. But there is one thing which is called tramadol. Despite being that an opioid, it is also having an additional mechanism of serotonin reuptake inhibition. So whenever there is serotonin reuptake inhibition by the tramadol, that can also precipitate an attack of serotonin syndrome, particularly if we are using MAO-A inhibitors for the Parkinson's treatment. So these clinical features are actually setting into serotonin syndrome, which are caused due to tramadol injection. So second option will be the right answer. Ibuprofen is just a simple NSAID. NSAID cannot actually cause this serotonin syndrome. Morphine is only a simple opioid. It doesn't have any excess of serotonin action. And oxycodone is also another opioid. Tramadol is actually having an additional serotonin activity, serotonin reuptake inhibition activity. That is the reason why it can precipitate an attack of serotonin syndrome. So if at all serotonin syndrome develops, no, we will give the drug of choice for the treatment is cyproheptadine. Cyproheptadine. Yes. We'll move to the next one. A patient presents with fever and a red, tender, swollen left knee, which started 2 days ago. He was recently diagnosed with hypertension and he has started a hydrochlorothiazide. Immediate joint aspiration is done and the microscopic picture is given below. Which of the following is the most appropriate initial management? The point that we have to highlight here is initial management. So what is the picture? The image here is showing a needle-shaped crystals which are actually negatively birefringent. So this actually makes our diagnosis very much obvious, which is actually an acute attack of gout. So in an acute attack of gout, our main intention is not to lower the levels of uric acid. Our main intention is to treat the inflammation. So for the acute attack of gout, NSAIDs are the drug of choices. So the initial management for this acute gout is going to be NSAID, which is nothing but naproxen. If at all we are dealing with a chronic gout, our intention will be to lower the levels of uric acid. So uricose uric agents, we will be using those. Of those, we have 2 different types. Uricose uric drugs, which are nothing but probenecid, and those which will decrease the levels of uric acid formation, which are nothing but xanthine oxidase inhibitors like allopurinol and febuxostat. This first line drugs that we use in chronic gout are allopurinol and febuxostat, but we cannot actually combine both these drugs together. Either of the class of the drugs only we should be using. So allopurinol will be started first. Before starting allopurinol, there can be hypersensitivity reaction to the allopurinol. So that we, to avoid that hypersensitivity reaction, we can actually check for HLA-B5801 morphology. If at all this is present, no, there will be a severe hypersensitivity reaction to the allopurinol and we should be careful for that. So the answer for this, because he is asking actually initial management for the acute attack of gout, the answer will be naproxen, which is a NSAID. Among the following statements, which is true regarding ecological study design? Ecological study design. It is expensive. Analysis done at the level of population. Association observed at the group level always holds true at the individual level. And complex study model. Ecological studies, they are not expensive. The information which is gathered is also secondary data. That means somebody else will collect the data for us and we will be using the data to analyze the reports. And analysis is done at the level of population. That is very true. And association observed at the group level always holds true at the individual levels is false statement. Whatever the result that we get, we cannot actually individualize to a single person. That is what we call as ecological fallacy. And it is a complex study model. No, ecological studies are very simple models. They are not complex study models. So this also cannot be the answer. It is done at the population level. The best example for this ecological study is nutritional survey. in nutritional survey, let's say we get a report like the children are malnourished. Not every child will be malnourished. Some will be overnourished, but majority might look malnourished. So overall, the survey tells the children are malnourished. That malnourished we cannot apply to each and every child in that population. So that is what is called as ecological fallacy. We cannot actually individualize the result to the particular person. Next question. During your rural service, a patient arrives at the outpatient department with a hypopigmented lesions over the trunk and the back. A woodlamp examination shows yellow gold fluorescence and fine scales, which become more and more prominent when the lesions are scratched with the fingernail. Which of the following organisms can cause this infection? Firstly, a hypopigmented lesion over the trunk and the back. What all we will think is it can be pityriasis versicolor or it can be leprosy as well. But the next one, which is telling, it shows a yellow gold fluorescence and the fine scales are becoming more prominent when they are scratched with the fingernail. This is actually called as Bessenier's sign, which is nothing but when we scratch the lesions, the fine scales accentuate. We get more and more scales. That is called as Bessenier's sign, which will be seen with pityriasis versicolor or tinea versicolor, which is actually caused by Malassezia furfur. This Malassezia furfur, it actually shows on a KOH mount, it will show spaghetti and meatball appearance or banana and grapes appearance. And it also shows fried egg colonies on olive agar. Fried colonies on olive oil agar. Yes. So the answer for this is Malassezia furfur. This Trichophyton, Epidermophyton, Microsporum, all of the infections. They cause the tinea, but not tinea versicolor. Tinea versicolor is caused by Malassezia furfur. Next, a 25-year-old newly married desires highly effective reverse contraception method that requires minimal user compliance. She specifically requires the method with the lowest typical use failure rate among the following options. Which of the following is the most appropriate choice? First thing, her desire is it has to be highly effective and it has to be a reversible contraceptive method with a minimal user compliance. So, taking combined oral contraceptive pills, it needs so much of effort for the woman to put and it needs a regular compliance. So, that is not the option for her. And it should have the lowest typical user failure rates. So, let us see what is the Pearls index for each of the contraceptive device. For a male condom with a typical use, it will be around 2. The Pearls index will be 2. Whereas for a female condom, it will be 5. For a combined oral contraceptive pill, it will be 0.3. For an implanon, it will be 0.05. For a copper T, it is 0.6. For a female sterilization, it is 0.5. For male sterilization, it is 0.1. So, out of everything, implanon has really the best failure rates, least failure rates. So, for her, that will be the best one because implanon doesn't need a regular follow-up and also implanon has least failure rates. So, that will be the most appropriate answer, appropriate contraceptive of choice for her. So, the option is 1, contraceptive implant, which is nothing but implanon. Next, in a laboring patient with a history of cesarean section, which of the following findings is least likely to indicate a uterine rupture? So, uterine rupture, how does they present? They will have definitely sudden sharp abdominal pain. They might have heavy vaginal bleeding. Yeah, this is okay. And decreased fetal heart rate. Definitely, fetal demise might happen if there is a uterine rupture. So decreased fetal heart rate will be seen. Because the uterus got ruptured, it will also not have any regular uterine contractions. So there will be absent uterine contractions. There can be vaginal bleeding, but it is not very heavy because there is a scar in the uterus. All those blood which is coming out, it will enter into the peritoneal cavity instead of coming out through the vagina. So there will be severe peritoneal bleeding rather than heavy vaginal bleeding. So that finding will be least likely in this patient. So heavy vaginal bleeding is not very much in a uterine rupture. There will be more of a peritoneal bleeding. Next. Which of the following medication is considered a first-line treatment for hirsutism in a woman with polycystic ovarian syndrome? Firstly, she wants to get treated first-line treatment for the hirsutism. For the first-line treatment of hirsutism, the drug of choices are combined oral contraceptive pills, in which generation will be either fourth generation because they are the one which will contain this anti-androgenic properties, less androgenic properties. So that will be helpful for this hirsutism. So first line of drug of choices are combined oral contraceptives, which are third or fourth generations. This spironolactone will be an add-on drug to this oral contraceptives. If at all we do not get a desired effect only with a simple combined oral contraceptives. So spironolactone will have this anti-androgenic property. So that will add on to this combined oral contraceptive pills. As a standalone, spironolactone is not considered as first-line treatment for hirsutism. First-line treatment for hirsutism in women with PCOS is combined oral contraceptive pills. Next, if because she wants to get treated for hirsutism, what if the question says she wants to conceive? What will be the first-line treatment for conception in that woman? That will be letrozole. For ovulation induction, we are using letrozole for women with PCOS. Next question. A 28-year-old woman with sickle cell anemia presents at 32 weeks of gestation with severe pain in her lower back, hips, and thighs. What is the next best management? She is already a known case of sickle cell anemia. Now she is having severe pain manifestations. What does this indicate? It indicates that it is a severe vaso-occlusive crisis. For a severe vaso-occlusive crisis, the initial management is give adequate hydration, because if there is dehydration, there is greater chances of the RBCs to get sickled and further worsen the condition. So intravenous fluids are a must, and definitely it will be a very painful situation. So pain management is a must. Okay. When will be exchange transfusion considered? Exchange transfusion will be considered if at all she develops an acute chest syndrome. Then we can actually consider doing exchange transfusion. So the correct option for this question will be intravenous fluids and pain management. Yeah, fourth option is intravenous fluids and close observation. We should also take care of the pain as well, because vaso-occlusive crisis is also known as painful crisis, which means the vaso-occlusive crisis are very, very painful. So if we do not manage pain, the patient will be in agony. So definitely we have to manage pain as well. So the fourth option with only just IV fluids and monitoring will not be enough. We have to take care of the pain as well. So intravenous fluids and pain management will be the best answer here. Next, what is the duration of the cardiac cycle for a heart rate of 180 beats per minute? It's a very simple question. So heart rate is 180 beats per minute. What will be the time for the each cardiac cycle? That means in 60 seconds, you are having 180 beats per minute. 180 beats. One beat will take how much time? So 60 by 180. It roughly comes around 0.33 seconds. Okay. So with a heart rate of 180 beats per minute, her cardiac cycle will be approximately around 0.33 seconds. The same can be done if at all he modifies any number instead of 180 beats. Next question. A 68-year-old male patient with a history of chronic heart failure has been experiencing worsening symptoms despite being on optical medical therapy, including AC inhibitors, beta blockers, and diuretics. His cardiologist decides to add a cardiac glycoside to his treatment regimen to improve his symptoms. Which of the following medication is not a cardiac glycoside? Okay. Digoxin, digitoxin, auben. All of these are cardiac glycosides. Doxorubicin is not a cardiac glycoside. In fact, it is an anti-cancer medication. It is not a cardiac glycoside. So, the answer for this will be doxorubicin, which is not a cardiac glycoside. Instead, digoxin, digitoxin, auben. All of them are cardiac glycosides. Which of the following statements on thrombolytics is false? Thrombolytics are nothing but recombinant tissue plasminogen activators, which we will actually use in stroke and in the case of MI. So, he is asking which of the following statement is false. First thing, they activate plasminogen to plasmid. That is what their mechanism of action is. Recombinant tissue plasminogen activator. They convert plasminogen to plasmid. So it is a true statement. And they act via tissue plasminogen activator. Definitely yes. And they are contraindicated in pregnancies. Definitely yes. And they can be used in NSTEMI. No. Thrombolysis should not be attempted in an NSTEMI because the bleeding risk is very high and the adverse effects are very high for thrombolysis in NSTEMI. So we cannot thrombolyze an NSTEMI MI. So the answer for this will be option 4. They cannot be used in NSTEMI. Thrombolysis is contraindicated in NSTEMI. Next question. It is on lipid metabolism. Okay. What is the total and net ATP used in the complete oxidation of arachidonic acid? So, in this, we have to see what is the number of carbons in the arachidonic acid. Okay. What is the total and net ATP used in the complete oxidation of arachidonic acid? For this, we have to know how much carbon does an arachidonic acid contain. Arachidonic acid is a 20 carbon fatty acid. And we also need to know what are the steps which are involved in fatty acid oxidation, and at each step how many ATPs are utilized and how many ATPs are synthesized. So let's go through that. Firstly, whenever there is a fatty acid outside the cell, first it has to get transported into the cell. So for that, it will enter into the cell, fatty acid, and it will get charged with the help of ATP, which will get converted into AMP and inorganic phosphate, which means it is utilizing 2 ATPs. And after completion of this charging of this fatty acid, it will get converted into fatty acyl CoA. Fatty acyl CoA. This fatty acyl CoA will actually start entering into the fatty acid oxidation pathway, of which every single time when a cycle occurs, it will actually remove 2 carbon acetyl CoA out of the fatty acid. Now, let's say this is 20 carbon fatty acid. When a single cycle goes, it will remove 2 carbons and we will be left with 18 carbons. 18 carbon fatty acid. And in the next cycle, again 2 more carbons will be gone and we will be left with 16 carbon fatty acid molecule. Till 2 carbons will be left and 2 cycles, 2 carbons at the end, like acetyl CoA will be left. This 2 carbons will be removed in the form of acetyl CoA. So, for this 20 carbons to become 2 carbons, every time we are removing the 2 carbon molecule, how many cycles will be necessary? So, it will be n by 2 minus 1, because at the end we do not have to process this 2 carbon leftover acetyl molecules. So, the number of cycles will be n by 2 minus 1. So, with every cycle, there will be synthesis of 1 molecule of FADH2 and 1 molecule of NADH. So, how many cycles will be there? N by 2 minus 1. With 1 FADH molecule, we will have 1.5 ATPs, and with 1 NADH, we will have 2.5 ATPs, which means which accounts to total of 4 ATP molecules. So, with every cycle, we will get 4 ATP molecules. Total number of cycles which we are having is N by 2 minus 1. So, total number of ATP will be into 4. This is coming from the cycle. What about the 2 carbon which is removed in the form of acetyl CoA? This 2 carbon which is removed from the acetyl CoA will enter into the citric acid pathway. So, every molecule of acetyl CoA will give me 10 ATPs. So, how many acetyl CoA molecules will I get? If it is an n number of carbon atom, I will get n by 2 acetyl CoA molecules. So, and I will have n by 2 into 10 ATP molecules every time. So, this is the total amount of ATP that I will be generating when when a n carbon atom fatty acid will be entering into the fatty acid oxidation. So, let us keep 20 in this n, because arachidonic acid is a 20 carbon atom. So, 20 by 2 into 10 plus 20 by 2 minus 1 into 4. 100 plus 36. A total of 136 molecules of ATP will be generated when an arachidonic acid will be oxidized. But what about the net? Net, here we are actually using a single ATP which is getting converted into AMP. That means we are already using 2 ATP molecules. So, net becomes total minus how many we have already consumed. So, the total will be 136 which has been generated. The net means total minus what we have already consumed during charging of this amino fatty acid. So, 136 minus we have utilized 2 ATPs, 2. So, the total will be, so the net will be 134. What is he asking? Total and net. So, 136 and 134. So, the answer is 1. Yeah, this is the very long one. We have to remember this. There is no other option. Just remember, there will be n by 2 number of acetyl CoA molecules and n by 2 minus 1 cycles. With every cycle, 4 ATPs, with a single acetyl CoA, 10. So, n by 2 into 10. That will be the formula to use in the future. Next. Which of the following case scenarios is not indicative of metastatic calcification? Which is not. The important thing here is it is not indicative of metastatic calcification, which means he is asking which of the following is dystrophic calcification. First option is a 60-year-old man with a history of chronic renal failure presents with shortness of breath and bilateral lung opacities on chest X-ray. He is already having chronic renal failure. So this looks like a metastatic calcification. Next, a 45-year-old female with spinal tuberculosis complaining of back pain. Spinal tuberculosis, that means the tissue which is present, it is already dead. So, the tissue there will get deposited with the calcium. That is what dystrophic means. Dystrophic. In the dead tissues, it will get deposited. The calcium will get deposited in the dead tissues. That is the reason we call it as dystrophic calcification. In dystrophic calcification, there will be normal levels of calcium. There will not be increase. There will be normal serum calcium levels. Whereas in metastatic calcification, serum calcium levels will be higher. So the next third option is a 30-year-old male with a long-standing history of heavy milk and calcium carbonate intake, now experiencing recurrent kidney stones. So now experiencing recurrent kidney stones tells me because he's already having heavy milk consumption and also calcium carbonate, which means he is having excess of calcium. This is indicative of milk alkali syndrome, which is again a metastatic calcification. Next, a 55-year-old female with sarcoidosis demonstrating elevated levels of serum vitamin D and calcium. Again, because the granuloma will have alpha hydroxylase activity, it will produce active form of vitamin D. So there will be increased levels of calcium. Again, this goes in favor of metastatic calcification. So the answer for this question will be 2, which is he asking about dystrophic calcification. So in a spinal tuberculosis, whatever there is a dead tissue, the calcium will get deposited there. So that will become an example for dystrophic calcification. The rest everything are metastatic calcifications. Next. A 20-year-old male is prescribed naproxen, which is an NSAID, okay, for musculoskeletal injury. What is the mechanism of action of NSAIDs? The action of NSAIDs is to inhibit COX, enzyme COX. There are two isoforms of COX enzyme, COX1, COX2. COX1 is actually constitutive. It is always expressed and it is a protective enzyme. Whereas COX2 can be induced. It is an inducible enzyme and this is the one which is responsible for the inflammatory mediators. So this is the culprit in inflammatory paths. So whenever we give NSAIDs, it will inhibit both of this. That means we will get both the positive effect and we will also lose this protective action over the gastric mucosa. So that is the reason why NSAIDs can actually induce peptic ulcers. So he is telling what is the mechanism of action of naproxen. So naproxen is going to inhibit both COX1 as well as COX2. After this, they thought that the COX1 inhibition is very bad. So let's develop a new drug which will be directed only against COX2. And they started developing atorvastatin and celecoxib, which are COX2 preferential COX2 inhibitors. But these had actually a higher cardiovascular mortalities. So that was the drawback for the COX2 inhibitors. These two are the mechanism of action of NSAIDs. They inhibit the COX1 and COX2 enzymes. Whereas paracetamol, PCM actually inhibits COX3. It does not inhibit COX1, it does not inhibit COX2, it inhibits COX3. It's a different enzyme which is inhibited by the PCM. So the answer for this will be COX-1 and COX-2 inhibition. Next. A 9-year-old boy is brought to the clinic with the swelling around the eyes, dark tea-colored urine, and decreased urine output. His mother reports that he had a skin infection, impetigo, about 3 weeks ago. The time period is 3 weeks ago. On examination, he has mild periorbital edema, elevated blood pressure. Urine analysis shows RBC casts and mild proteinuria. Serum studies reveals low C3 complement levels. A renal biopsy is performed and electron microscopy reveals the following changes. Which of the following is the most likely diagnosis? Even with the history, we can actually make a diagnosis of post-streptococcal glomerulonephritis. This impetigo can be the source of this streptococcal infection. And this time period of 3 weeks, after which he developed all these clinical manifestations, it is the time which is required for our body to get sensitized and to attack the renal system. That is the reason why there is a time period of 3 weeks after infection till the development of PSGN. So the answer will be post-streptococcal glomerulonephritis. Here we will actually have subepithelial infiltrates. In PSGN. What if it is not 3 weeks and it is just 2 days or less than a week and it's an elderly one? Instead of a young child, if he is an elderly, old, then the same nephritic picture in an elderly becomes IgA nephropathy, which is also called as synphalangitic nephritic syndrome. Because at the onset, almost immediately parallel to the onset of this infection, they will have this nephritic picture. So it is synphalangitic. Next. You are provided with the results of receptor status from the biopsy obtained from a patient's breast lump. You realize that her molecular subtype carries a low proliferative rate and a better prognosis. Which of the following will not be the likely histological subtype in this patient? So, first we will know about the molecular classification of the breast cancer. In this molecular classification of breast cancer is actually based and divided into luminal type A, luminal type B, HER2 enriched, and triple negative breast cancer. So in this luminal type A and luminal type B, the only difference is proliferative rate. Luminal type A will have low proliferative rate and luminal type B will have high proliferative rate. This is actually based on gene expression profiling. So let's see what are the examples which come under luminal type A, type B, HER2 enriched and triple negative breast cancer. In luminal type A, we will have tubular, papillary and low grade invasive lobular carcinoma. Whereas in luminal type B, we will have high grade invasive lobular carcinoma. Whereas in HER2 enriched, we will have apocrine carcinoma. And in triple negative, we will have metaplastic carcinoma and medullary variant of breast cancer. So he is asking which of the following, the question says it has low proliferative rate and a better prognosis, which means he is actually asking us about this luminal type A. That means he is asking which of the following is not a luminal type A type of breast cancer. So tubular carcinoma is a luminal type A breast cancer. Papillary carcinoma is a luminal type A breast cancer. Mucinous carcinoma is also a luminal type of breast cancer. Luminous type A breast cancer. So metastatic medullary carcinoma is triple negative breast cancer. So this is the answer for this question. Next, a 45-year-old woman with a history of moderate alcohol use undergoes general anesthesia for an emergency appendectomy. The anesthesiologist uses halothane for induction and maintenance. 2 weeks later, after the surgery, the patient presents with fatigue, nausea, jaundice, tender hepatomegaly. Laboratory tests reveals the following, where AST is elevated, ALT is elevated, bilirubin is also elevated, direct is elevated more. Which of the following best explains the patient's condition? From this history and all, we can make a diagnosis of halothane induced hepatitis. Halothane hepatitis. But we can actually rule out this third one and fourth one because it is not due to liver failure precipitated by the surgical stress, and it is also not post-operative sepsis. So we are left with either direct hepatotoxicity of the halothane or immune-mediated hepatotoxicity of the halothane. So to get to the answer, look at this time frame. It is 2 weeks. It is not immediate. Immediately after giving halothane, if she develops, it might be direct hepatotoxicity. But why is this 2 weeks time taking? Because this halothane will form a compound against which immune mediated reaction happens. So for all this sensitization, it takes 2 weeks. So this halothane hepatitis in this patients which is occurring after 2 weeks, it is actually immune mediated hepatotoxicity of the halothane. So just with this help of this 2 weeks, we can actually come to an answer either in 1 or 2. 2 weeks because it is taking time. It will be an immune mediated hepatotoxicity of the halothane. Next, what is the most commonly fractured bone in cases of basilar skull fracture? In this is actually a most commoner one we have to remember sometimes. The most commonest bone to get fractured in the basilar skull fractures is temporal bone. In temporal bone, we have two different type of fractures. One is a longitudinal fracture. One is transverse fracture. Longitudinal means that it is along the long axis of the petrous bone, whereas transverse fracture means it is transverse to the petrous bone. So there are two different types, longitudinal and transverse. Longitudinal axis to the temporal bone petrous part. Transverse means it is transverse to the petrous part of the temporal bone. So here, because it is longitudinal, it will generally spare the otic capsule. What it will involve is the tympanic membrane and the ossicles. So this temporal bone longitudinal fracture generally produces a conductive hearing loss. Whereas a transverse fracture, it will actually involve the otic capsule and the inner ear. So this will actually produce a sensory neural hearing loss. So there is difference. Longitudinal will actually produce a conductive hearing loss, and a transverse fracture produces a sensory neural hearing. So, the most commonly fractured bone in case of basilar skull fractures is a temporal bone. A forensic pathologist examines a body and notes the following findings. What do these findings suggest of? He is asking what are these findings suggest of? They are actually hesitation cuts or hesitation marks, which is nothing but even before a prior main cut, they will have some hesitation cuts. So, the individual experienced a moment of hesitation before the fatal injury. Yes, they are actually hesitation cuts. The injuries were caused by a blunt object. No. The victim was attacked with a sharp instrument from a distance. No. The wounds are consistent with the homicide. No. These he is asking about these. These marks are actually hesitation cuts. So the answer for this question will be option 1. Next one. A 30-year-old male is brought to the emergency department after experiencing severe anxiety and chest pain following a night of partying. He reports using cocaine, and the medical team notes his elevated blood pressure and signs of agitation. Which of the following is the most likely complication of cocaine use? So, cocaine. Cocaine is actually a sympathetic stimulant. So, a sympathetic stimulant, if had there been a morphine, it would have caused respiratory depression, urinary retention. So, these two can't be. Because it is a sympathetic stimulant, it will actually increase the heart rate, resulting in some forms of cardiac arrhythmias. So, the most likely complication following a cocaine intake and experiencing this chest pain and severe anxiety following taking this cocaine would most likely suggest a cardiac arrhythmia secondary to cocaine intake. Next, a 48-year-old female with diabetes presents with severe, sharp right-sided facial pain triggered by light touch along with numbness and tingling. Examination shows hyperesthesias and decreased sensations on the right side. Which of the following structure is most likely involved in this condition? So he is asking what structure of the sensations carried from the face is involved here. So the sensations from the face will actually be carried by trigeminal nerve. Yeah, the clinical diagnosis is it is not Deseret rosary, it is actually trigeminal neuralgia. So he is asking which of the following structure is most likely involved in this condition, which is nothing but having hyperesthesias and pain. So let us look at the sensations from the face. Which is the nerve which is carrying sensations from the face? It is the trigeminal nerve. So trigeminal nerve will have three nucleus. The one mesencephalic nucleus, principal or a chief sensory nucleus, and the last one is the spinal nucleus. So each of the nucleus has its own functions. The first one is mesencephalic will actually carry the proprioception, whereas the spinal one will actually carry the pain and temperature. The rest sensations will be taken care by the principal and the chief sensory nucleus. So what is he asking? Facial pain triggered by light touch and numbness and tingling and hyperesthesias and decreased sensations of the right side. So the pain which is coming from the face is actually taken care by the spinal nucleus. So he's asked which of the following structure is most likely involved in this condition. So it is spinal nucleus of the trigeminal nerve. Next, which of the following is the function of ventral posteromedial nucleus within the ventral group of nucleus of the thalamus? So just remember VPM, VPL. VPM, M means mouth and face. VPL means limbs. So VPM nucleus receives the sensations from the face, whereas VPL nucleus receives the sensations from the limbs. So if we know this, it will be very easy. VPM, he is asking, ventropostural medial nucleus within the ventral group. Motor activity influences the motor activities by connecting with the premotor cortex. No, this is not its function. Receives the sensory information from the cerebellum and the red nucleus. This is also not the answer. This is the trigeminal and gustatory pathways. Exactly. This is what is being carried by trigeminal to VPM mouth and to the VPM nucleus. Projects to the primary motor areas of the cerebral cortex. This is also not the function. So VPM carries sensation from the mouth and the face, whereas VPL it receives the sensations from the limbs. So the answer for this will be receives trigeminal and gustatory pathways. The VPM receives the trigeminal and gustatory pathways. Next, a 35-year-old patient presents with symptoms of cavernous sinus thrombosis, including severe headache, visual disturbances, and facial swelling. Which of the following is not a tributary of the cavernous sinus? Superior ophthalmic vein definitely is a tributary of cavernous sinus. Inferior ophthalmic vein is also a tributary of cavernous sinus. And sphenoparietal sinus is also a tributary of cavernous sinus. This deep facial vein is not a tributary of cavernous sinus. So with this, we will actually see the venous drainage of the face. Venous drainage of the face. First, this is supratrochlear vein. Supraorbital vein will form an angular vein joined together with the facial vein. And behind the ear, let's say this is the ear, this is the eye, and this is the mandible. The eye. So behind the ear, there will be posterior auricular vein. And from here, superficial temporal vein will be joining together with the maxillary vein. And it will actually form the retromandibular vein. And this retromandibular vein will get divided into two, a posterior division and an anterior division. This posterior division of retromandibular vein will actually join this posterior auricular vein and it will form external jugular vein. This is posterior auricular vein. This is retromandibular vein. This is posterior division of this retromandibular vein, anterior division of retromandibular vein, supraorbital vein, supratrochlear vein. This will be superficial temporal vein. This will be maxillary vein. Okay. This angular vein will actually join the facial vein. And this facial vein together with the anterior division of the retromandibular vein will form a common facial vein. And this common facial vein will actually drain into the internal jugular vein. So, this deep facial vein will actually form a connection between the facial vein and the pterygoid venous plexus. And from this pterygoid venous plexus, through an emissary vein, it will be connected to the cavernous sinus. So, deep facial vein as a directly doesn't involve directly with the cavernous sinus. This deep facial vein will connect the facial vein to the pterygoid venous plexus, and this pterygoid venous plexus will get connected to the cavernous sinus with the help of emissary vein. So, deep facial vein is not a contributory of cavernous sinus. So, the answer for this will be option 3. Next. A 58-year-old patient presents with a large right-sided intracranial tumor. During neurological examination, the patient is found to have right-sided hemiparesis. Which of the following explains this paradoxical neurological finding? Normally, whenever there is a tumor on the right side, we will get a hemiparesis on the left side. But here, we are getting a hemiparesis on the right side, which is nothing but a paradoxical finding. So, what is the reason behind this paradoxical finding? It is actually Kernohan's notch phenomenon. Let us see once. So, let's say this is a cranium. This is the midline. Let's say we have a large tumor or a hematoma of one side. Let's say this is the right side, this is the left side. If there is a tumor, first it will start pushing it to the opposite side. So first there will be a midline shift. After midline shift, what happens is, if we do not intervene, the uncus will start herniating through the tentorium. So while the uncus is starting to herniate through the tentorium, it will actually compress on the third cranial nerve of the ipsilateral side. So, ipsilateral pupil will be dilated. If we do not intervene here also, it will be furthermore uncal herniation, and it will start impinging on the contralateral third cranial nerve. So, whenever there is impingement on this contralateral third cranial nerve, there will be contralateral pupillary dilation. So, what we generally expect, if there is a problem on the left side, the pupil should be dilated on the left side. But here the pupil is dilated on the right side, which is the paradoxical finding. This is what is called as Kernohan's notch phenomenon. A pathology on the left side will manifest externally as a contralateral manifestation, which is a false localizing sign. That is what is Kernohan's notch phenomenon. So the answer for this paradoxical neurological finding is Kernohan's notch phenomenon. Next, a 45-year-old man presents with bright red bleeding per rectum during defecation and the mass that prolapses through the anus during the bowel movements. The prolapsed mass does not reduce spontaneously but can be manually pushed back into the anal canal. Which degree of internal hemorrhoids is the patient most likely to have? So, first degree of hemorrhoids, they do not appear outside, but they bleed. That is first degree of internal hemorrhoids. Whereas second degree, they do appear outside, but they spontaneously go back. Whereas in third one, they appear outside, they do not go back spontaneously. But they can actually be manually be repositioned back into the anus. Whereas the fourth one, we cannot even manually reposition back them. So he's telling that they does not reduce spontaneously, but they can be manually pushed. which means they belong to grade 3 of the internal hemorrhoids. So this will be grade 3, third degree internal hemorrhoids. So the next question. A 10-week-old infant is brought for routine immunization. The infant received the birth dose of hepatitis B vaccination, but missed the scheduled vaccination at 6 weeks. Which of the following should be administered at this visit according to the national immunization schedule? So let's go through the options first. In a 10-week-old, why will we give HPV vaccination? So this is not the answer. And MMR and vitamin A, both of them will be given at 9 months. So even these two cannot be the answers. So the leftover is option 1. We will give bivalent OPV, pentavalent rotavirus vaccination, and also fractionated IPV1 and pneumococcal conjugate vaccine first dose. So we can approach even through elimination of the options. Next, coming to the which of the following statements is incorrect with respect to type 1 von Gerkes disease and type 3 Cory's disease, glycogen storage disease. First, let us see what is von Gerkes disease and Cory's disease. Von Gerkes disease is glycogen storage disorder type 1, whereas Cory's disease is glycogen storage disorder type 3. The problem in von Gerkes disease is glucose 6-phosphatase, which is the terminal enzyme which is responsible for the release of glucose molecule into the blood. Whereas Cory's disease, the problem is with the debranching enzyme. So let's go through the options. Type 1 glycogen storage disorder is characterized by enlarged kidneys, while type 3 typically has a normal kidney size. Very true. So, glycogen storage disorder type 1, there will be excess of fat which is getting deposited in the kidneys as well as in the liver. So, there will be enlarged kidneys in glycogen storage disorder type 1. The same finding will not be seen in Cory's disease. Next, muscle involvement is seen in type 3 glycogen storage disease, but not in type 1 storage disease. Yes, because the glucose 6-phosphatase, the glucose which is coming into the body is coming from liver. Muscle never contributes to the blood glucose. So, muscle involvement will not be seen in type 1 glycogen storage disorder, whereas it will be seen in type 3 glycogen storage disorder. This is also a true statement. Lactate levels are typically normal in glycogen storage disorder type 3 and they will be elevated in type 1 glycogen storage disorder. Yes, lactate levels will be elevated in type 1 glycogen storage disorder because whatever the glucose 6-phosphatase is there will be diverted to form lactic acid. So, type 1 glycogen storage disorder will have higher levels of lactate, but it is not the case with type 3 glycogen storage disorder. Type 3, the lactate levels are typically normal. Next, fourth option is liver biopsy in glycogen storage disorder type 1 shows fibrosis, while type 3 shows some distension of the hepatocytes by glycogen and fat deposition. This is actually opposite. Type 1 glycogen storage disorder, there will be deposition of glycogen and fat in the hepatocytes. So, the wrong option will be option 4. Glycogen storage disorder type 1 will have a glycogen and fat deposition in the liver, not the glycogen storage disorder type 3. Next, a 55-year-old male presents with fever of 38.5 degrees centigrade that has persisted for 3 weeks. He reports there is a significant weight loss, night sweats, and fatigue. His medical history is unremarkable. On physical examination, he is having splenomegaly and cervical lymphadenopathy. Which investigations would be most appropriate next step in this patient's management? With this weight loss, night sweats and fatigue, and persistent fever for 3 weeks, we can actually even think of tuberculosis, TB. But to evaluate further for the splenomegaly and cervical lymphadenopathy, we have to get this CT of the abdomen as well as the pelvis. Chest X-ray, blood cultures, and HIV testing can be done once the TB is confirmed. So the next step to evaluate for this splenomegaly and cervical lymphadenopathy would be a CT of the abdomen as well as the pelvis. Not just simple chest X-ray, blood cultures, and HIV testing. We have to evaluate even for this splenomegaly and cervical lymphadenopathy as well. So the CT of the abdomen and pelvis will be a better answer in this question. Next. A 45-year-old woman presents with progressive muscle weakness and a distinctive rash on her eyelids as well as knuckles. She also exhibits a rash as shown in the given image. She reports difficulty swallowing and has experienced some joint pains as well. Which of the following statements about this patient's condition is false? With this muscle weakness and the involvement of the skin, we can actually think of dermatomyositis. So this dermatomyositis will have skin manifestations as well as muscle manifestations. Skin manifestation in the form of this shawl sign or V-neck sign. This is actually a V-neck sign. And myositis in the form of proximal muscle problems, proximal muscle weakness. We can just remember it like dermatomyositis is a proximal muscle weakness, like this. No, so he's asking which of the following statement is a false statement. The rash may precede or accompany the muscle weakness. Okay. Weakness is typically asymmetrical, affecting the distal muscles more than the proximal muscles. No, dermatomyositis is predominantly a proximal muscle weakness rather than distal muscle weakness. So this looks like a wrong statement. Nail-bed telangiectasias are a common findings. Yes, we can see nail-bed telangiectasias in this dermatomyositis as well. Patients may present only with a rash and no muscle weakness. This is also possible. So he's asking which of the following statement is a false one. So dermatomyositis is a proximal muscle weakness rather than the distal muscle weakness. So the answer will be option number 2. Next, coming to immunology. A 30-year-old woman comes to the clinic with severe respiratory infection. The physician explains the body's immune response, detailing the roles of different immune systems in fighting infections. Which of the following statement about innate and acquired immunity, as explained by the physician, is a false statement? Innate immunity provides a rapid response to the infections without a prior exposure to the antigen. Definitely yes. Acquired immunity develops over time and it requires a prior exposure to the antigen. Yes, only when it is exposed to the antigen, it will get sensitized, and whenever the antigen comes the next time, it will react immediately. That is acquired immunity. Innate immunity has immunological memory and can recognize specific antigens. No, innate immunity doesn't have any memory and it doesn't respond to a specific antigen. It doesn't have an immunological memory. This function is actually an acquired immunity function. Acquired immunity involves T cells, B cells, which are specific to particular pathogens. Yes, sir. So what he is asking, he is asking false statement. So the answer will be option 3. It's just like innate immunity is like reading just before the exam. We will anyway crack the exam. But acquired immunity is like reading from the beginning more sensitivity, more specificity. Whereas innate immunity, we do not have any sensitivity and specificity, but eventually we'll crack the exam. Just like that, we can remember that. Next. A 45-year-old male presents to the emergency department with severe abdominal pain, vomiting, and distended abdomen. On examination, his bowel sounds are diminished. Abdominal radiography is given below. What is the most likely diagnosis for this patient based on the given findings? So, what is this X-ray showing? It is showing multiple air fluids level 1, 2, 3, 4. 4 air fluids levels. Multiple air fluid levels. And also, this abdominal pain, vomiting, and distended abdomen are also telling, and also bowel sounds are diminished. All of this is pointing towards an intestinal obstruction. So, how I will know whether it is small intestinal obstruction or a large intestinal obstruction? Look where the intestine is present mostly. The air fluid levels we're actually seeing in the central part, not in the peripheries. If we see here, obstruction in the form of hostra, then we can actually think of large bowel obstruction. But we are actually seeing more in the central part. More in the central part. So the intestines are more in the central part. So it will be a small bowel obstruction based on this X-ray. The option will be option 2. Yes. Which of the following is a characteristic finding in the fundus examination of a patient with Stargardt's disease? So this kind of named fundus appearances in optal, we have to remember some of those. Like beaten bronze appearance. This is the one which is actually seen in Stargardt's disease. Whereas egg yolk appearance is seen in breast disease. Honeycomb appearance is actually seen in cystoid macular edema. And one thing we can actually rule out is silent choroid. Silent or dark choroid is actually an angiograph finding. It is not a fundoscopy finding, it's an angiograph finding. So we don't have to think in terms of. So the answer for this question will be option 1. Beaten bronze appearance is seen in Stargardt's disease. Next. In case of civil medical negligence, the burden of proof primarily lies on. If the burden of proof in a civil negligence, it will lie on the patient. The patient has to state what the patient has to prove that the doctor has not delivered his duty properly. He is already in the duty, and the onus to prove that the doctor has did a wrong thing. The burden lies on the patient to prove. So the burden of proof primarily lies on patient in case of a civil medical negligence. In majority of the cases, it will actually lie on the plaintiff rather than the accused. So here the patient is the one who has to prove primarily the negligence. Next. A post-operative patient with prolonged immobilization develops cough pain, local warmth, and tenderness. On examination, pain increases with passive dorsiflexion of the foot. What is the most likely diagnosis? Based on this prolonged immobilization, cough pain, and a post-operative patient, and local warmth and tenderness, we can actually think of deep vein thrombosis. A cough, unilateral cough, swelling, and pain following a prolonged immobilization, DVT could be a very likely reason for this. So, and also the pain increases with the passive dorsiflexion of the foot. This again further points towards a deep vein thrombosis. So option for this answer will be option 2, which is deep vein thrombosis. A drug prescribed for type 2 diabetes stimulates pancreatic insulin release by closing the ATP sensitive potassium channels in the beta cells. Which drug acts by this mechanism? So, meglitinides. The mechanism of action of this meglitinides is that they close the potassium channels inside the beta cells, ATP sensitive potassium channels. So the potassium actually stays inside the cell, which will actually cause more amount of positive in the cells. So there will be depolarization, which will open the calcium channels. So there will be entry of the calcium. This calcium will actually drive the insulin out of the cells. So meglitinides has this mechanism of action, which is ATP sensitive potassium channels will be closed, resulting in the release of insulin. So meglitinide, repaglinide is an example of this meglitinide. So the answer for this question will be option number 2. Next, what is the initial management of choice for a patient who is diagnosed with a large pyogenic liver abscess? So, first, option 1, surgical resection of the affected liver segment. Surgical resection of the liver segment, it will be too aggressive to approach at the first beginning itself. Immediate open surgical drainage will also be too aggressive. Empirical intravenous antibiotics and percutaneous drainage. Yeah, this has to be done whenever there is a pyogenic liver abscess. Endoscopic retrograde cholangiopancreaticography with a stenting. That will be done whenever there is a problem with the biliary tract. The problem here is not with the biliary tract. It is with the hepatic architecture. It's not with the biliary tract. So there is no point in doing ERCP with stenting here. We have to give empirical intravenous antibiotics and perform a percutaneous drainage here. So option for this question will be option number 3. A 58-year-old man with long-standing diabetes mellitus presents with blackish discoloration and necrosis of the toes. This looks like dry gangrene. As shown in the image, he reports long-standing numbness of both foot and markedly reduced ability to perceive the pain. Which of the following statements regarding the underlying condition is false? So, ischemia contributes to the tissue necrosis. Definitely yes. It is the ischemia which is causing a reduced perfusion to the peripheries, resulting in this necrosis. So, immunosuppression has no role. If the main problem with this higher sugar levels is it will cause immunosuppression, so your body cannot fight against the infections. So, immunosuppression definitely had a role in the pathogenesis of this dry gangrene. So, this will be a false statement. Sensory neuropathy occurs early. Yes, diabetic sensory neuropathy can also occur. So, whenever there is trauma, the patient will not be able to realize that he got a trauma. So, he will not take care of that. So, that eventually will progress. And motor neuropathy can also cause callosities in the soul. Definitely, yes. Callosities are nothing but thickenings. Whenever there are contractions, they will result in the formation of callosities in the soles because of the abnormal posturing or abnormal alteration of the arches of the foot. So this is also possible. So the answer for this will be immunosuppression has no role. Immunosuppression is present here because of this higher sugar levels, long-standing diabetic mellitus. Next. Which of the following colonic polyps is associated with the most malignant potential? So polyps, colonic polyps. There are two different types of colonic polyps. One is non-neoplastic. One is neoplastic. In non-neoplastic, there will be inflammatory polyps. What does this inflammatory polyps look like? They are nothing but like ulcerative colitis, pseudo polyps and all. Another one is hyperplastic polyps. And the next one is hamartomatous polyps. Like juvenile rectal polyps. Whereas coming to the neoplastic polyps, there will be sessile serrated adenoma. And tubular adenoma. Villus adenoma. And tubulovillous adenomas. Of all these, this villus adenoma has the most malignant potential. So he is asking which of the colonic polyps is associated with the most malignant potential. Inflammatory polyp is a non-neoplastic polyp. Juvenile polyp is also a non-neoplastic polyp. Hyperplastic polyp is also a non-neoplastic polyp. So the sessile serrated polyp is the one which is a neoplastic polyp. So the one with the most malignant potential will be the sessile serrated polyps. This sessile serrated polyps, throughout its thickness, it will have this serrated glands throughout its thickness. Whereas in hyperplastic polyps, there will be serrations, but only limited to the upper part. The lower part will be nice round. There will be no serrations. That is how we can actually differentiate between sessile serrated and hyperplastic polyp. Next, according to FIGO staging of cancer of the vulva, a tumor that has spread to the inguinal lymph nodes is classified under which stage? So remember 1, 2, 3 and 4. 1 is confined to the vulva. 2 has reached the adjacent structures like urethra, vagina, anus. Whereas 3, it has gone to the inguinal lymph nodes. 4, metastasis or other lymph nodes. So he is telling there is spread to the inguinal lymph nodes of this vulval cancer. So the stage of this cancer will be stage 3. So the option will be number 3. So whenever there is inguinal lymph nodes involvement in the vulval malignancy, the stage will be third stage. Next, certain discrete segments in the DNA known as jumping genes can move in cut and paste manner between the different DNA molecules. What is the defining characteristic of these molecules? First, they are independent replicons that can replicate without a host genome. No, they cannot self-replicate and must be integrated into the host DNA molecules. Yes, they are exclusively found in the eukaryotes and are absent in the bacteria. No, transposons are jumping genes. They are present in both eukaryotes as well as prokaryotes. They move between the cell only through the process of translation. No. So, transposons, let's say there is a gene, there is 2 chromosomes. One, let's say this is the jumping gene. This jumping gene can actually move from one place to another place. But they cannot replicate as an independent particle without this host DNA. They must get integrated first so as to replicate. So they cannot self-replicate and they must be integrated into the host DNA. Yes, they cannot do an independent replication. And they are found in both eukaryotes as well as prokaryotes, and they are not just exclusive to the eukaryotic cells. They can only move through the process of translation. No, that is also a wrong statement. So the answer will be option number 2. A 42-year-old man with a long-standing liver disease presents for evaluation. His clinician suspects chronic viral hepatitis. Among the following hepatitis virus, which one is most likely to progress to chronic infections in adults? You can just remember hepatitis C. In this hepatitis C, C just means it is chronicity. You can remember this like this. In hepatitis C, C means chronicity. So, he is suspecting chronic viral hepatitis. And which hepatitis virus is notorious to produce this chronic infection in adults? So it will be hepatitis C. Hepatitis A and E, they are known to produce acute viral hepatitis. Hepatitis D can also be chronic, but mostly it is associated with hepatitis C. Chronicity, chronic viral hepatitis is associated with hepatitis C. Yes. Identify the component of multi-drug therapy shown in the image below, which is used as a standard treatment for adult leprosy patients. He is asking, what is this blister packet indicative of? Is this a pediatric blister packet? In the question itself, he asked it is used for the treatment of adult leprosy patients. How can this be a pediatric blister packet? It can't be the answer. Loose capsules of rifampicin. They are not loose capsules. It's a simple, neat blister packet which is consisting of rifampicin, clofazimine, and also dapsone. And a single dose of ROM regimen. It's not a single dose. It is a monthly dose as well as a daily dose. Dapsone is given daily, 100 mg. So the answer will be, it is an adult blister pack for MDT. A 70-year-old hypertensive man is brought to the emergency department with sudden onset of dizziness and palpitations for 2 hours. His ECG is given below. Which of the following drugs would be ineffective in management of this patient? So, firstly, we have to know what is this ECG telling us. Firstly, there are no, actually, if we see, there are no P waves. And the R waves are also not regular. So it is likely atrial fibrillation. So amiodarone, diltiazem, and also digoxin, all of these can work for atrial fibrillation. Whereas mexiletine, which is nothing but a oral form of lignocaine, they do not act for atrial arrhythmias. They work only for the ventricular arrhythmias. So mexiletine, because this is atrial fibrillation, mexiletine, he is asking which of the following drug would be ineffective in managing this arrhythmias. So mexiletine will not be effective in managing this atrial fibrillation arrhythmia. So the answer will be option number 3. A 26-year-old man is brought to the emergency department with fever, intense headache, photophobia, and neck stiffness for the past 48 days. With this, I can think it could be a meningitis. During physical examination, a maneuver demonstrated in the attached video clip elicits pain and resistance on passive extension of the knee while the hip is flexed to 90 degrees, which is nothing but Kernick's sign. This finding is most suggestive of which of the following conditions? Guillain-Barré syndrome? No. Acute bacterial meningitis? Yes. This is what we are thinking from the history as well. And transverse myelitis? No. Cauda equina syndrome? Also no. So the two signs of this meningitis are Kernick's sign and Brudzinski sign. Both these signs are can be elicited in meningitis. So the answer for this question will be option number 2, which is acute bacterial meningitis. A 46-year-old man presents with sudden painless loss of vision in his right eye. During ocular examination, a swinging flashlight test demonstrated in the attached video is performed. When the light is moved from the left eye to the right eye, both the pupils paradoxically dilated instead of constricting. The finding is most consistent with the lesion involving which of the following structures? Firstly, when a flashlight is thrown into the eye, it is supposed to constrict, but instead it is paradoxically dilating, which is indicative that it is an RAPD, relative afferent pupillary defect, which is actually seen with optic nerve problems. So we can actually rule out this oculomotor. But now we are actually left whether it is a left optic nerve or a right optic nerve. For this, the swinging flashlight is demonstrated when the light is moved from the left eye to the right eye. That means I am throwing light into this right eye. When I am throwing light into this right eye, it is supposed to constrict and it is also supposed to produce a consensual light reflex in the opposite eye. But because this right eye, the optic nerve is not working properly, this is actually producing an RAPD. So instead of constricting, it is producing dilation, which is RAPD. So the problem is with the right-sided optic nerve rather than the left optic nerve and the left oculomotor nerve, and also right oculomotor nerve. RAPD means we should actually think in terms of optic nerve problems, because this RAPD is getting elicited whenever we throw light into the right eye. The problem is with the right eye's optic nerve. So the answer will be option number 4. A 25-year-old male recreational athlete presents with pain over the knee joint, intermittent locking, and difficulty in squatting following a twisting injury while playing football 2 weeks ago. During examination, maneuver demonstrated in the attached video produces a painful, palpable click along the joint line. Injury to which of the following structures is most likely? From this history, we can actually think that there could be an injury to the meniscus, because see, it's producing a painful palpable click along the joint line. This makes us think of a meniscal injury. So in this video, this video is actually demonstrating McMurray test. I was not able to open this here. McMurray's test we will be doing to find out the injury to the menisci, medial menisci. So even from the history, we can make out that it is an injury to the menisci, and this McMurray test is actually done to find out injuries to the menisci. So the answer will be option number 3, which is meniscus. A patient with a shoulder injury is examined as demonstrated in the attached video, which highlights the muscle responsible for the initial movement of the shoulder abduction after the first few degrees. Weakness of the muscle shown is most likely due to injury to which of the following nerves? Here, the muscle which he is showing is nothing but deltoid. He is asking what is the nerve supply of deltoid? What is the nerve supply of deltoid? Deltoid will be supplied by the axillary nerve. That's it. So the answer for this will be option number 2. Next. A 6-year-old child is brought to the ophthalmological clinic because the parents have noticed inward deviation of one eye since early childhood. During ocular examination, a maneuver demonstrated in the attached video is performed. The uncovered eye moves outwards to regain the fixation when the fellow eye is covered. This finding is most consistent with which of the following diagrams? So, there are actually two different tests, which is cover test and another one is uncover test. This cover test is actually used for tropias. That means it is actually a manifest squint. That means we can see that the eye is deviated at the first place itself. Whereas this uncover test is used for phorias, which is used to like for the latent squint. Let us say the patient has actually deviation of the eye. We know it is squint, but we don't know whether the problem is with this eye or the problem is with this eye. So what we will do is we will cover the eye. We will cover one of the eye and we will look for the movement in the other eye. So what happens is, let's say I have covered, let's say this is the problematic eye and this is the normal eye. When I cover this normal eye, what happens? This one will try to look for the normal ones. So whatever it has gone outside, it will move in the opposite direction. So this inside, this will be coming towards the inside. That means the problem is with the eye which has got deviated outside. That means this will be right-sided exotropia because it is already a manifest squint. What if this eye is the problematic eye? Here we thought it is right eye which is the problem. Let's say the problem is with the left eye now instead of the right eye. So whenever I cover this right eye, what happens is this will move in the opposite direction. So that means this will move towards the inwards. So by this we can actually get to know which eye is the problematic eye, whether it is the right one or the left one. So the tropias can be identified through the cover test, whereas uncover test is done to identify the phorias. So now look at this. The uncovered eye actually moves outwards to regain the fixation. That means I have covered one of the eye and the uncovered eye has moved towards the outwards. That means previously it is inwards. So that means it is an esotropia. So the uncovered eye actually moved towards the outside. That means previously it is actually inside. Whenever I covered this actually tried to compensate for the normal eye. So it has actually moved out. That means previously it is inside. That means esotropia is present. So the answer will be option number 1 for this. Next. Match the following drugs to their mechanism of action. Paracetamol inhibits COX-3. This we actually already discussed. Paracoxib, it will inhibit only COX-2. With this, D is option 1. So with this itself, we can actually make it option 1. Next, aspirin inhibits both COX-1 as well as COX-2, whereas meloxicam is a preferential COX-2 inhibitor. So from this, we can tell the answer is option 1. Paracetamol inhibits COX-3, an entirely different enzyme, not COX-1, not COX-2. It inhibits COX-3. So the answer will be option number 1 here. What is the main focus of the Pradhan Mantri Poshan scheme launched by the government of India? So, empowering women through nutritional developmental programs, improving nutritional outcomes among the children, promoting sustainable agricultural practices, providing financial assistance for the rural agricultural development. It is actually nothing but midday meals program. So this midday meals program is initiated to improve the nutritional outcome among the children. It is not something related to women empowerment nor agricultural practices, and it is not to assist the rural agricultural development. It is to improve the nutritional outcomes among the children. A doctor finds that many patients do not follow his advice regarding medication and lifestyle changes, even when he explains the scientific base clearly and patiently. What communication factor should this doctor prioritize to improve his patient interaction in his context? So there is something barrier which is preventing the patient from following the doctor's advice. So what is that? Sharing humorous anecdotes to ease the patient's anxiety. This is done, but this is not to overcome the barrier. This is done to build a rapport between doctor and the patient. So understanding the local cultural beliefs and practices related to the health and illness. So this is the one which is actually barrier which is stopping patients from following the doctor's orders. So he should actually understand the local cultural beliefs and practices related to the health illness and guide the patient according to them. So only then they will be able to follow this doctor advices. Using complex medical terminology to establish his authority and expertise. This is absolutely wrong statement. Focusing solely on conveying the information about the latest advancements in the medical sciences. No, this will also be a wrong option. The option will be answer. So the answer will be option number 2. Yes. National health. Which of the following is are the components of the National Health Mission? This National Health Mission, it includes all. National Rural Health Mission, National Urban Health Mission, RMNCHA, and also communicable and non-communicable. Everything will fall into this umbrella of the National Health Mission. So which of the following is or are components of the National Health Mission? So the answer will be all of them. Everything falls into this National Health Mission only. Which of the following is a primary vector responsible for transmitting the plague to the humans? Plague to humans, the transmitting vector is Xenopsella cheopis. So the answer will be option number 3, which is this Xenopsella cheopis is rat flea. This is the one which will actually transmit plague to the humans. So the option will be 3. A 28-year-old traveler returning from a malaria endemic region presents with high-grade fever, chills and sweating. Physician orders a thick blood film as well as thin blood smear as a part of the diagnostic workup for malaria. What is the primary purpose of the thin smear in malarial diagnosis? We make 2 smears so that in the thick smear we can actually quantify the malarial parasite load. Quantify the load. Whereas thin smear, we make a thin smear so as to speciate them. Whether this Plasmodium falciparum, Plasmodium vivax, Plasmodium malaria or so well, for speciation we make a thin smear. So this smear will be stained with JSB, Jashwant Singh Bhattacharya stain. So what is he asking? What is the primary purpose of the thin smear in malarial diagnosis? So thin smear is done for the speciation. To detect the presence of malarial parasites? No. To determine the species of the malarial parasite, we will actually do this thin smear. To assess the degree of anemia? No. To measure the parasite load? This is for the thick smear, but he is asking about thin smear. So to determine the species of malaria, we will actually do this thin smear. So the answer will be option number 2. A 30-year-old woman develops a dusky red to brown patches on her arms and legs after taking an antibiotic for sinusitis. The lesions are mildly pruritic, recur at the same sites with re-exposure to the medication. This is the most important line. Recur at the same site with re-exposure to the medication and heals with a persistent hyperpigmentation. What is the most likely diagnosis? Based on this diagnosis, even without looking image, we can make a diagnosis of FDE, which is nothing but a fixed drug eruption. Again and again at the same location, they will get a mild pruritic rash at the same site, fixed drug eruption, fixed at the same site, and healed with hyperpigmentation. So the answer will be option number 1. A 32-year-old woman complains that the tips of her finger changes from pale white to bluish red during the winter. So this is telling it's a Raynaud's phenomenon. She reports that the symptoms began 5 years ago but has worsened recently. She also complains of difficulty in swallowing. Which of the following findings would you expect in this patient? Hypercalcemia, calcinosis cutis, a malar rash, and a morphia. So the answer will be calcinosis cutis. This is actually a case of systemic sclerosis. This systemic sclerosis is actually in two forms. Localized form and a systemic form. In localized form, it can be two types. Either it is circumscribed or it can be linear. Whenever it is circumscribed, we call it as a morphia. In linear form, we call it as M2P sabre. Whereas in systemic, we have two different types. One is limited systemic sclerosis and another one is diffuse systemic sclerosis. This limited systemic sclerosis is CREST syndrome. And the antibody in this is anti-centromeric antibody. And whereas in this diffuse systemic sclerosis, the antibody will be anti-SCL70 antibody. So what are the acronyms for this CREST? Calcinosis cutis, Raynaud's, esophageal dysmotility, sclerodactyly, and lastly telangiectasis. And this anti-centromeric antibody, it actually correlates with the pulmonary artery hypertension more than interstitial lung diseases. Whereas this anti-SCL70 antibody, it correlates with the interstitial lung disease more than the pulmonary artery hypertension. Systemic sclerosis patients, they have a tendency to develop a pulmonary artery hypertension. So anti-centromeric antibody correlates more with pulmonary artery hypertension, whereas anti-SCL70 antibody correlates more with this interstitial lung diseases. So the answer will be option number 2, which is calcinosis cutis. What the question system is asking is about CREST syndrome. Okay. Next one. A 32-year-old pregnant woman at 34 weeks of gestation presents to the emergency department with sudden onset of vaginal bleeding and severe abdominal pain. On examination, her abdomen is tender and she shows some signs of fetal distress. What is the most likely cause of bleeding in this patient? With this gestational age, we can actually think it's an antepartum hemorrhage, definitely. So, an antepartum hemorrhage, 2. Abruptio placentae and placenta previa. The question is telling it's a tense and a severe abdominal pain. A tense and a tender uterus tells it is an abruptio placenta, whereas placenta previa, there will not be tense or there will not be tenderness or there will not be any abdominal pain. It will be silent, bright red. So, based on this question stem, because it is telling that it is abdominal pain and also there is a tenderness on palpation, it is abruptio placenta. So, the answer will be option number 2. If it is a silent one without any tense or tenderness, it will be placenta previa, because the question is telling she is having severe abdominal pain and on examination also which is having tenderness, that points out towards abruptio placenta. Which of the following statements is true regarding the ECG leads? Chest leads are bipolar limb leads in a horizontal plane. Okay. Positive ends of the voltmeter is connected to the Wilson's terminal. In lead 2, the negative end is in the right arm. Augmented limb lead is polar. If I was to answer this question, I would have skipped this question because I do not know much about this. So, but only one thing we know is this is lead 1. This will be lead 2 in Netherlands triangle. This for the lead 3. This is negative, negative, positive, positive, negative, positive. So let us see, is anything fitting? In lead 2, the negative end is the right arm. This is right, this is left, this is left foot. Left arm, right arm. In lead 2, this is lead 2, the negative end is the right arm. Only this I know, and this is actually fitting. And what is he asking? Which of the following statements is true regarding the ECG leads? Only option that I know is option 3. If I were you, if I do not know this, I would have skipped this question. And sometimes we don't need to know each and every point. We can just know only one, and that might be present in the options. We can just go by that. Which of the following statement correctly differentiates cardiac muscle from the skeletal muscle? Cardiac muscle cells are multinucleated, while skeletal muscles have a centrally located nucleus. Okay. Cardiac muscles form a functional syncytium with intercalated disc. Skeletal muscle lacks these structures. True. Cardiac muscle as a whole it is contracting because it has got a functional syncytium because of the presence of gap junctions at the intercalated disc. Whereas skeletal muscles do not have a specific intercalated disc and gap junctions. Cardiac muscle contraction is voluntary. No, it is not voluntary, it is involuntary. And regulated by the somatic nervous system. Skeletal muscle contraction is involuntary. No, skeletal muscle contraction is not involuntary. Cardiac muscle primarily utilizes glycolytic pathway for the energy, whereas skeletal muscle relies solely on the oxidative metabolism. Actually, cardiac muscle they depend on the fatty acids because fatty acids actually produce more amount of ATP, which is actually needed by the cardiac muscle. So, rather than relying on glycolytic pathways for the energy, cardiac muscle primarily relies on the fatty acid oxidations for this energy. So, the answer will be option number 2, which is cardiac muscle performs as a functional syncytium because of the presence of intercalated disc, and in the intercalated disc there will be gap junctions. So the answer will be option number 2. Okay. Which of the following factors can cause denaturation of the DNA? Denaturation means the strands will get separated. Okay. Increasing temperature, definitely yes. Decreasing temperature, no. So option 1 has to be present in the answer. So it has to be either this or this. And next, increasing salt concentration. I am not sure about that. DNA with a high AT base composition, DNA with a high GC base composition. GC base composition will have 3 hydrogen bonds, whereas AC composition will have only 2 hydrogen bonds. So it will be easier for me to denaturate a AT based composition higher ones. So denaturation of the DNA will also be dependent on this base composition. So this should also be present. So D is present. Yeah, I don't know the remaining one, but I know that the AT will have 2 bonds, GC will have 3 bonds. It is easier for me to break AT bonds rather than GC bonds. So I choose A and D. So A and D are present in option number 3. So I'm going for this. The rest everything I do not know. Only by knowing these two I can mark this option number 3. What is the correct equation to calculate the catalytic efficiency of an enzyme? This is actually a memory point. You just have to remember catalytic efficiency means Kcat by Km. If there is a, this is a formula to remember. That's it. So the answer will be option number 1. A 65-year-old male with a history of hypertension and coronary artery disease presents with worsening shortness of breath and orthopnea. Chest X-ray revealed pulmonary condition. Bronchoalveolar lavage shows hemosiderin-laden macrophages as shown in the image. What is the most likely diagnosis? These hemosiderin-laden macrophages are heart failure cells. That means there is pulmonary condition due to heart failure. So which heart failure will produce pulmonary condition? It will be left-sided heart failure. Right-sided heart failure will actually produce systemic condition rather than pulmonary condition. So these heart failure cells are seen with left-sided heart failure. A 55-year-old male presents to the clinic with complaints of recurrent abdominal discomfort and changes in the bowel habits over the past few months. Further investigations with colonoscopy confirmed the presence of adenocarcinoma. Which of the following factors is most closely associated with this adenocarcinoma? So, taking estrogen hormone replacement therapy is actually protective for colonic cancer. Taking high fiber diet is also protective for colonic cancer. Use of aspirin is also protective for colonic cancer. But taking red meat is actually a risk factor for colonic cancer. So it's telling which of the following factor is most commonly associated with this condition. So consumption of the red meat will be responsible for this adenocarcinoma. So the option will be option number 4. Which of the following statements is correct regarding the normal metabolism of vitamin B12? So first let us look at this. Normal vitamin B12, it will enter and in the stomach, intrinsic factor will be there in the intestine at the terminal part of the ileum. So in the saliva itself, we will have haptocorrin. So B12 will enter inside like this and it will be bound with haptocorrin plus vitamin B12. And after coming into the duodenum, it will get detached. And it will combine with intrinsic factor. After coming into the terminal part of the ileum, it will get separated as intrinsic factor plus vitamin B12. And this vitamin B12 will be now absorbed by the transcobalamin 2. That means this haptocorrin is produced in the saliva only, but it will not bind with B12 in the mouth. It will bind with B12 in the stomach. Intrinsic factor is produced in the stomach, but it will not bind with the B12 in the stomach. It will bind in the intestine. So at the end, intrinsic factor will get separated and this B12 will be absorbed by the transcobalamin 2 into the body. Now let us see. He's asking which of the following statements is correct regarding the normal metabolism of the vitamin B12. Haptocorrin from the salivary glands binds to the vitamin B12 in the stomach. True statement. Next, it is absorbed in the duodenum. No, it is absorbed in the terminal part of the ileum. So B must not be present. So this cannot be an answer. Gastric enzymes play an important role in splitting the haptocorrin and vitamin B12. Yes. It is stored primarily in the liver and it has a larger reserve capacity. Yes, this is also a true statement. It acts as a cofactor for converting homocysteine to the methionine and methylmalonyl CoA to the succinyl CoA. Definitely yes, sir. So, methionine to methylmalonyl CoA. The coenzyme which is required, cofactor, vitamin cofactor which is required is vitamin B12. So, even this last answer is also correct. It acts as a cofactor for converting homocysteine to the methionine and methylmalonyl CoA to the succinyl CoA. I'm sorry. Which is methylmalonyl CoA carboxylase. Carboxylase is the enzyme which will convert methylmalonyl CoA to the succinyl CoA, which needs vitamin B12. So whenever there is deficiency of this vitamin B12, this methylmalonyl CoA levels will be raised. So we can actually test that whenever we are suspecting vitamin B12 deficiencies. So the correct answers will be option A, D, and E. So the answer will be option number 2. A 45-year-old male with depression treated with lithium carbonate 300 milligrams 3 times daily develops vomiting, abdominal pain, dizziness, and nystagmus, muscle weakness, and slurred speech. What is the most likely serum lithium concentration responsible for these symptoms? So we understood that it is a case of lithium toxicity. So lithium toxicity 0.5 to 1.2 will be a therapeutic value. After 1.5, all these symptoms of dizziness, nystagmus, muscle weakness, or milder forms will appear. So the answer will be option number 1.5 to 2 milliequivalent, because beyond 2.5 milliequivalents, he will not just simply have vomiting, abdominal pain, dizziness. He might actually land up into coma or seizures. These levels are very much higher for this clinical manifestations. The clinical manifestations are bit on a milder side. So 1.5 to 2 milliequivalents, the patient will actually have clinical manifestations of this abdominal pain, dizziness, nystagmus, and muscle weakness. Beyond that levels, he will have even further more severe manifestations in the form of seizures, either in the form of coma. A 6-year-old child is frequently admitted with gastrointestinal distress, including vomiting and abdominal pain. The mother provides elaborate details about the symptoms and insists on multiple tests despite the negative results. Symptoms appear only when the mother is present and the child seems healthy when separated. What is the most likely diagnosis for this child's condition? This is Munchausen syndrome by proxy. Mothers will actually inside some illness to the child, and they will actually bring the child to the hospital for the care. That is not a true illness for the child. Mother is actually inside in the illness. That is actually called as Munchausen syndrome by proxy. Munchausen syndrome is different from Munchausen syndrome by proxy. Munchausen syndrome is they themselves will inside some of the illnesses and they'll come to us to seek medical attention. Whereas Munchausen syndrome by proxy, they'll bring others because they will create some illness to them and they'll bring them to our notice. That is bringing them like a proxy. So it is Munchausen syndrome by proxy. So option 2. A 32-year-old woman presents with progressive vague pain and swelling around the right knee for the past 3 months. Examination reveals there is tenderness, swelling over the distal femur. Histopathology demonstrates there are numerous multinucleated giant cells scattered among the spindle-shaped mononuclear stromal infiltrates. So the following statement regarding this tumor is a true. So multinucleated giant cells. What is this telling? Is a giant cell tumor. So what is the true statement about this giant cell tumor? He is asking. It commonly arises from the diaphysis of the long. No, it actually arises from the epiphysis of the long bone. It is benign but can behave locally aggressive. Yes, this is actually a true statement. It most frequently metastatizes to the regional lymph nodes. No, it doesn't metastatize to the regional lymph nodes. It actually metastatizes to the lungs. It most commonly affects individuals under the age of 20. No, it actually appears after the skeletal maturation. After 20 years of age. So the answer will be option number 2. It is a benign tumor, but it can actually behave locally aggressive sometimes. Okay. Which of the following best describes the external neurolysis? External neurolysis. Freeing a nerve from the surrounding scar tissue, dissecting the nerve sheath to separate the fascicles, altering the course of a nerve, sacrificing unimportant nerve branches. So he is asking external neurolysis. External neurolysis means freeing a nerve from the surrounding scar tissue. Dissecting the nerve sheath to separate the fascicles is internal neurolysis. So the answer will be option number 1. Which of the following best describes the drainage pathway of the sinus that is marked with the arrow in the image? So here the image is actually marking a frontal sinus. And he is asking frontal sinus will be opening into the which meatus? Either superior meatus or middle meatus or an inferior meatus. So frontal sinus will be opening into the middle meatus. Into the superior meatus, let's come from the inferior one. So the inferior meatus, there will be opening of the nasolacrimal duct. Into the middle meatus, majority of them will be opening into the middle meatus. In the superior meatus, behind the superior meatus, there will be sphenoethmoidal region, where the sphenoidal sinus will be opening. And into the superior meatus, posterior ethmoidal air cells will be opening. The rest, everything, anterior, middle, as well as the frontal sinuses, all of them will be opening into the middle meatus. Into the sphenoethmoidal region is the sphenoidal sinuses. In the superior meatus is the posterior ethmoidal sinuses. And in the inferior meatus, it is nasolacrimal duct. The rest, everything will open into the middle meatus only. The image here marked, that arrow is actually showing a frontal sinus. So frontal sinus will be draining into the middle meatus. A newborn presents with significant cyanosis and a single large vessel exiting the heart on imaging. Echo shows a defect in the interventricular septum. What embryological failure led to this condition? Actually, during the development, there should actually be a septum which is formed between the truncus arteriosus, so that it will get actually separated into the pulmonary artery and the aorta. After formation of the septum, there should be spiraling of the septum, so that the aorta and the pulmonary artery will be changed like this. So failure to do so will result in some of the abnormal conditions. So failure of the formation of the atrioventricular septum itself, it will actually form persistent truncus arteriosus. And failure of the aorticopulmonary septum to spiral, if they do not spiral, they will actually remain like this. So there will be transposition of the great arteries and anterior displacement of the septum. Whenever whenever the septum comes anteriorly, there will be pulmonary stenosis. So this pulmonary stenosis will result in right ventricular hypertrophy and this VSD, resulting all of this in the tetralogy of Fallot. So in this tetralogy of Fallot, there will be anterior displacement of the septum. So he's asking a defect, echo shows a defect in the interventricular septum, which embryological, there is actually single large vessel exiting from the heart. Oh, okay. This is not persistent truncus arteriosus. Sorry. So single large vessel which is existing from the heart, it is saying is the persistent truncus arteriosus. It is formed because there is a failure of the formation of the conotruncal ridges to form. So answer will be option number 2. A 62-year-old male presents to the emergency department with sudden onset of severe vertigo. There is also bilateral hearing loss and tinnitus. He also exhibits facial weakness on the right side and demonstrates ataxia when attempting to walk. MRI is performed to evaluate the condition is given below. Which artery is most likely to be affected in this condition? So he's actually having an additional middle ear problems as well. So which of the following artery will be supplying the middle ear as? So middle cerebral artery and superior cerebellar artery and vertebral artery, they won't be supplying the inner ear. Anterior inferior cerebellar artery is the one which will actually supply the inner ear as well, because he's already also having this inner ear problems. So anterior inferior cerebellar artery will be the answer for this question. A 20-year-old man presents with a painless midline neck swelling that has been present since the childhood and has gradually increased in size. On examination, the swelling moves upwards on protrusion of the tongue. Ultrasound reveals a cystic midline neck lesion. Which of the following statements regarding this condition is correct? So, what is he telling? It's a thyroglossal cyst. So, which of the following condition about this state is correct? It is a high risk of developing a squamous cell carcinoma. Okay. Removal of the cyst along with the tract and the central part of the hyoid bone is performed. Yes, this is what is called as cistrum procedure. It is most commonly seen in the suprahyoid. No, it is actually seen in the subhyoid region. Incision and drainage are preferred management. We don't actually do incision and drainage because of the fear of formation of the fistula. Instead, we will actually remove the entire tract along with the cyst. This is what is the cistron procedure. Along with that, we will remove the middle part of the hyoid bone as well. That is cistron procedure. So, incision of drainage is not at all performed. So, he asked which of the following is a correct statement. So, removal of the cyst along with the tract and the central part of the hyoid bone is performed. Cistron is performed. That is the correct answer. Next. Okay. A 10-year-old child presents with bilateral hearing loss of higher tones and has episodes of vertigo, and on examination there is prominent forehead and linear scars and spoke wheel-like pattern around his mouth. Which of the following signs is not seen in this disease? So, he is having bilateral hearing loss along with episodes of vertigo are present. There is a prominent forehead and linear scars in a spoke-like pattern. All of this is pointing out towards congenital syphilis. So in congenital syphilis, why do we actually see Gottron papules? These are Gottron papules. So which of the following is not seen in this stage of the disease? So Gottron papules will not be seen. Option number 2. A 13-year-old boy who has upper respiratory infections presented with recurrent episodes of blood in his urine and as well as hypertension. A renal biopsy reveals IgA deposition in the mesangium. Which of the following is the most appropriate initial treatment for controlling this condition? So what is this? Following an upper respiratory tract infection, he is having recurrent episodes of blood in his urine as well as hypertension. This is IgA nephropathy because there is also deposition of the IgA in the mesangium. So, the initial treatment for this condition will be ACE inhibitors or ARB inhibitors. So, the answer will be option 2. Which of the following is the most sensitive as well as specific diagnostic test for detecting the pheochromocytoma? For detecting the pheochromocytoma, plasma-free metanephrine will be used. But to confirm or for the diagnostic test, 24-hour urinary fractionated metanephrin will be a better answer. But because he is asking to detect the pheochromocytoma, plasma-free metanephrin are the first initial investigation that we actually perform. So the answer will be option number 1. Had if he asked what is the diagnostic test, we can actually answer 24-hour urinary fractionated metanephrins. You are an intern who is posted in the ICU. Nurse calls you to assess the patient with septic shock who suddenly becomes unresponsive. She has already started high quality CPR and the cardiac monitor shows the following ECG rhythm. What is the next best step in the management of this patient? So, what is this rhythm actually showing? This is actually a ventricular fibrillation. Ventricular fibrillation and the patient is in shock. So, the next thing is to shock him. So, we will actually defibrillate. So, the answer will be option number 2. A 18-year-old boy with severe hemophilia, factor 8 activity is less than 1% is scheduled for a wisdom tooth extraction. He has a history of recurrent hemarthrosis and no inhibitors for factor 8. Which of the following is the best strategy to prevent the perioperative bleeding? So, whatever is deficient, we can just supplement it to him so that he will not have the manifestations. So, give prophylactic factor 8 concentrates to raise the blood levels by greater than 50% before the procedure. So, that will be a better answer. Because we actually have the option of giving factor 8 concentrates, whatever is deficient, we can just replace it with him. So, give prophylactic factor 8 concentration so that the blood level will rise from less than 1% to the greater than 50% to avoid this risk of complications. So, the answer will be option 3. A 30-year-old man is brought to the emergency department after a road traffic accident. During a primary assessment, he is disoriented and complains of severe headache. Examination reveals neck stiffness and other meningeal signs. An NCCT of the brain is shown below. What is the most likely diagnosis? There is actually enhancement here, which we can actually see, which indicates that there is a bleeding into the systems. So bleeding into the systems means it is actually a subarachnoid hemorrhage. Subarachnoid hemorrhage can also have this neck stiffness and meningeal signs. And this is actually called star of death. So the answer will be a subarachnoid hemorrhage. The amount of alcohol consumption, what amount of alcohol consumption is generally considered to significantly increase the risk of developing alcoholic hepatitis? This is actually a factual question. So we have to remember that more than 50 grams per day alcohol consumption is actually a risk factor for developing alcoholic hepatitis, more than 50 grams. A 45-year-old man presents with progressive exertional dyspnea. There is also dry cough, fatigue, and weight loss for the past 6 months. He works as a pigeon breeding facility and reports long-term exposure to bird proteins. There's a long-term exposure. HSCT of the chest demonstrates regular opacities, GGOs, and also there is fraction bronchitis. Which of the following statements regarding his condition is true? It is caused by type 1 hypersensitivity reaction mediated by IgE antibodies. This is a chronic hypersensitivity pneumonitis. So, type 1 hypersensitivity, no. Type 1 hypersensitivity, it will be acute. Because he is having a long-term exposure and there is also features of traction bronchitis suggesting that there may be fibrosis in the lungs. It is a chronic hypersensitivity pneumonitis. This is not type 1 hypersensitivity reaction. Pulmonary fibrosis is known complication of chronic hypersensitivity pneumonitis. Definitely yes. Acute hypersensitivity pneumonitis presents several days after an antigen exposure. No, it will actually present very early, not after several days. HSCT is typically normal in a hypersensitivity pneumonitis. It can actually show GGOs, it can actually show some fibrosis as well as traction bronchiectasis. So typically they are not normal in hypersensitivity pneumonitis. But pulmonary fibrosis is actually a known complication of the chronic hypersensitivity pneumonitis. So this will be the answer. hypersensitivity to this bird breedings, bird droppings, anything. Next. 30-year-old woman presents with rash and difficulty in breathing after being administered penicillin. Which of the following type of hypersensitivity reaction is most likely responsible for her symptoms according to the Jellicoe's classification? This is a type 1 hypersensitivity reaction where there is a previous exposure to the antigen, they already got sensitized. Whenever there is a re-exposure, immediately the body will respond. So that is the type 1 hypersensitivity reaction. Next, a 20-year-old male arrives at the emergency department after a road traffic accident with multiple fractures. The orthopedic team plans to stabilize his injuries using internal and external fixators. MRI is required to assess the soft tissue injuries. Which of the following orthopedic fixation is usually compatible with MRI? So, K-wires, uniplanar fixators, external fixators with aluminum rods, internal fixators with titanium. Actually, titanium is actually compatible with MRI. So currently all these implants are actually being made by titanium. So internal fixation with titanium are actually compatible with MRI. So we can actually perform MRI even though there are titanium implants in the body. So the answer will be option number 4. A 30-year-old woman undergoing controlled ovarian hyperstimulation for in vitro fertilization presents with abdominal pain and marked abdominal distension. Which of the following ultrasound finding most reliably differentiates ovarian hyperstimulation from the polycystic ovarian syndrome? So, in a setting of ovarian in vitro fertilization and for this ovum retrieval, there can be induction for this ovulation. So, there might be a risk of developing ovarian hyperstimulation syndrome. So, he is asking which of the following ultrasound finding most reliably differentiates this OHS from the PCOS. OHS, ovarian hyperstimulation syndrome, it will actually have ascites, whereas this PCOS will have thick echogenic stroma of the ovary. And the presence of multiple cysts, which are 2 to 9 mm. And ovarian volume of greater than 10 mm. All these features are actually pointing towards PCOS, echogenic stroma, ovarian volume of greater than 10 ml, multiple cysts which are measuring 2 to 9 ml. The only thing which might point us towards ovarian hyperstimulation syndrome is the presence of ascites. So option 3. Next, a 40-year-old man presents with progressive enlargement of his hands and feet, increasing ring as well as shoe size. 4 facial features, excessive sweating, arthralgia, and newly diagnosed diabetes mellitus. Serum IGF is elevated and growth hormone fails to suppress following the oral glucose tolerance test. MRI of the cellar demonstrates that there is a pituitary mass. What is the most common underlying etiology of this condition? From this, we can understand that it is a growth hormone producing tumor. Growth hormone producing tumor, which are nothing but somatotropes. Somatotrophic adenoma. Now look at the options. Ectopic growth hormone releasing hormone secretion from the bronchial carcinoid. But here he is telling MRI of the cell is actually demonstrating a pituitary mass. Why will a bronchial carcinoid will be shown in an MRI in the cella mass? So it cannot be the answer. A pure somatotrophic pituitary adenoma. Yes, this somatotrophic pituitary adenoma is the one which is releasing growth hormone and causing all of this manifestation. A lactotrophic adenoma with stalk effect. Lactotrophic adenoma, it will actually have another manifestations like galactorrhea and amenorrhea and infertility. It's not a hypothalamic hamartoma. All these features are actually pointing out towards growth hormone excess. So growth hormone excess coming from a pure somatic pituitary adenoma. So option number 2. The patient presents with acute right upper quadrant pain and systemic toxicity. CT abdomen shows air within the gallbladder without any evidence of biliary enteric communication. What is the most likely diagnosis? It's telling that there is systemic manifestations and there is also air within the gallbladder, but there is no evidence of biliary enteric communication. If there is biliary enteric communication, we might think of fistula. But without there being a communication between the biliary and enteric system, but there is still gallbladder, air in the gallbladder, and there is features of systemic toxicity, which indicates it's an emphysematous polycystitis. Air in the gallbladder without a biliary enteric communication tells it is an emphysematous polycystitis. A 31-year-old woman undergoes a transvaginal ultrasound for suspected ectopic pregnancy. The sonographer identifies an extrauterine tubal ring sign. Upon activation of the color Doppler, a ring of fire appearance is noted. What does this Doppler finding specifically represent? Okay, reversal of flow in the uterine artery. That doesn't actually show us like a ring of fire. Increase the resistance in the spiral arteries. No. Peritrophoblastic flow with a less resistance. Yes, this is the answer. Because in the ectopic, there will be a G-sac here. And the peritrophoblastic, there will be spiral arteries. There will be peritrophoblastic flow with low resistance. That is the reason why whenever we switch on a Doppler, we will have this ring of fire appearance. A torsed vascular pericle of the ovary will not have this ring of fire appearance like this. So the answer will be peritrophoblastic flow with the low resistance. Next, which of the following does the Starling's law imply? What is Starling's law? Within physiological limits, the amount of the stretch will be directly proportional to the contractility of the heart. Increased blood pressure leads to increased cardiac output. No. Increased discharge leads to increased cardiac output. No. Increased venous return leads to increase in the cardiac output. Yes. Whenever there is increased venous return to the heart, there will be greater stretch on the myocardium. And within physiological limits, if there is a greater stretch on the myocardium, there will be greater contraction of the heart. That is what is Starling's law. So the answer will be option number 3. A gravida 3 para 2 RH sensitized woman at 29 weeks of gestation is found to have fetal height drops on ultrasound. Photosynthesis is performed. What fetal hematocrit value is the standard indication for immediate intrauterine blood transfusion? This is a value that we actually should remember, that below 30% of the hematocrit of the fetus, there has to be intrauterine blood transfusion. So it's just a numerical number that we should remember. Less than 30%, we have to transfuse. Intrauterine transfusion has to be done. In patients with HIV or AIDS, which of the following is the most frequently observed brain tumor? Most frequently observed brain tumor in a setting of immunosuppression, particularly in HIV and AIDS patients. So that will be a primary CNS lymphoma. That could be in the form of DLBCL. So answer will be option number 2. Most commonly observed brain tumor in HIV or AIDS patient will be primary CNS lymphoma. A clinician performs a gram stain on a vaginal smear from a patient with malodorous vaginal discharge. The smear reveals epithelial cells with fuzzy border due to adherent bacteria and new inflammatory cells. These findings are characteristics of. He is actually telling a description of flu cells. Epithelial cell with fuzzy borders due to adherent bacteria and inflammatory cells. This is the epithelial cell upon which there are two adherent bacteria. So flu cells. So flu cells are actually a findings of bacterial vaginosis. So option number 3. Next. A researcher compares proportion of smokers across 3 different populations to determine whether the observed difference is statistically significant. Which statistical test is most appropriate for this purpose? To calculate the arithmetic mean of a large population? No. To test the significance of difference between two or more proportions? Yes. To determine the linear correlation between height and weight? No. To measure the standard deviation of a single sample? No. He actually wants to compare the proportion of smokers across the different populations to determine whether they are significant or not. So he has to compare between two or more proportions. So the test of significance of the difference between two or more proportions will be used. So let us discuss about this test of significance. There are two different types of statistical tests of significance. One we can actually use for quantitative data. One we can actually use for qualitative data. Whenever there is normal distribution, we can actually use this test, normally distributed. But whenever there is skewed data, we can use these tests. And if we want to compare mean or standard deviation, we can actually use this test. But whenever we want to compare proportions or percentages, whenever we want to compare the proportions or percentages, we can actually use these data. So what are those tests? So what are those tests? Here we will have paired t-test, unpaired t-test, and ANOVA test. Here we'll have sign test, sign rank test, and chi-square test. Here in paired t-test, it is the same group but before and after the intervention. Let's say I want to compare hemoglobin in a group before giving iron and folic acid and after an iron folic acid. So then I will use this paired t-test. But this unpaired t-test will be used whenever I want to compare two different groups. I want to compare mean of hemoglobin in one group and mean of hemoglobin in another group. Then I will use this unpaired t-test. If I want to compare mean of hemoglobin in more than two groups, then I will use this ANOVA test. So exactly the same. The paired test is similar to this sign rank test, and this chi-square will be used similar to this unpaired test and ANOVA t test. Okay. A 24-year-old man presents with an acute onset of abdominal cramps and watery diarrhea after consuming food from a roadside stall. Stool culture is performed and the organism is grown on eosin methylene blue agar as shown in the image. The colony appearance seen in the image indicates that the positive organism is best described as which of the following. So here it is showing actually a green color colonies, which indicates that it is a strong lactose fermenters. The appearance of green color colonies on eosin methylene blue agar is indicating that they are strong lactose fermenters. Okay. Next, which of the following represents the correct order of the hierarchy of evidence from the highest to the lowest? So, highest will be the meta-analysis. Meta-analysis is nothing but the analysis of all the analysis which have been done. Next, systematic review. Next comes the randomized control trials. Next comes the cohort studies. Next comes the case control. Next comes the case reports. So this is the hierarchy in the evidence-based medicine. First comes the meta-analysis and the systematic reviews. Next comes the randomized control trials. Next comes the cohort. Next the case studies. At last comes the case reports. So the answer will be option number 3. A 12-year-old child is noted to have a keyhole-shaped defect in the inferior iris on eye examination. Which developmental defect is responsible for this anomaly? So, he is actually having a coloboma. So, why is this coloboma appearing? Because there is failure of the embryonic fissure to close. Whenever, whenever there is a failure of the embryonic fissure to close, it cannot close completely. It will be defective either either up or down. That will result in formation of the colobomas. Persistence of the hyaloid artery can actually cause persistent hyperplastic primary vitreous. This cannot cause colobomas. There will be defective failure of the embryonic fissure to close. So that is the reason why we will get colobomas. So the answer will be option number 3. 35-year-old man presents with chronic cough, weight loss, and low-grade fever for the past 6 weeks. Sputum culture grows acid-fast bacilli on LJ medium. Which of the following is the most common ocular manifestation associated with this condition? So what is he asking is, what is the most common ocular manifestation of the tuberculosis? So the most common ocular manifestation of the tuberculosis is granulomatous uveitis. You just have to remember this most common ocular manifestation. A 24-year-old man complains of recurrent itching and transient linear waves over his forearms after a minor scratch. The examination technique demonstrated in the attached video is performed using a blunt instrument. The skin develops erythematous raised linear wheel within a few minutes. This response is primarily mediated by which of the following? What is he typically telling is dermographism. Wheel reaction. Triple response. So what is he telling? Why is it occurring? Keratinocyte apoptosis? No. Histamine release from the mast cells? Yes, that is the one which is causing all this triple response. A T cell mediated inflammation? No. IgG on autoantibodies directed against desmoglein? No. So this triple response or this dermographism is actually mediated by the histamine release from the mast cells. So the option will be 2. A 29-year-old man presents to the emergency department with painful involuntary spasms of the calf muscles following several days of persistent vomiting. During physical examination, the muscle contractions demonstrated in the attached video are observed. Which of the following electrolyte abnormality is the most likely underlying cause for this clinical finding? So what is it telling? It is having painful involuntary spasm of the calf muscles. So which is nothing but twitches. Tetany. So tetany is occurring because of the hypocalcemia. So which of the following electrolyte abnormalities most likely resulting in this clinical finding? So low calcium, which is hypocalcemia, is the one which is causing this tetany. The clinical description is suggestive of tetany. A 36-year-old woman presents with perioral tingling, intermittent muscle cramps, and numbness of the hands following thyroid surgery performed 1 week ago. During examination, a maneuver is demonstrated in the attached video is performed, resulting in the carpopedal spasm. This clinical finding is most likely due to which of the following electrolyte abnormality? Again, the same thing. Again, low calcium levels, increased excitability, resulting in all of these features. So again, it is hypocalcemia. Following a thyroid surgery, there is a chance that the parathyroids might have been removed. So that can result in low calcium levels, resulting in this tetanus features. So hypocalcemia. A patient who was diagnosed with rheumatic heart disease now presents with irregular involuntary movements of the upper lips and head alongside a characteristic darting movements of the tongue. So the following drugs is least likely to be used in the management of this presentation. So what is he telling? He is having irregular involuntary movements of the upper limbs, which is telling it's a side enhanced chorea. And the characteristic darting movement of the tongue, which is actually called as jack in the box. The characteristic darting movements of the tongue. Jack in the box movements. Which of the following drugs is least likely to be useful in the management of this patient? Trihexyphenidat is actually an anticholinergic. Haloperidol, sodium valproate, carbamazepine. All of this can actually sedate and actually can reduce this involuntary movements. Whereas anticholinergics, they can actually aggravate all these movements. So, which of the following drugs is least likely to be used in the management of this patient will be trihexyphenidat. We cannot use this because it can actually aggravate all these Sydenham chorea movements. Which of the following is an ionotropic receptors? Receptors from endocrine is very, very important. Every single paper will definitely have one question from the receptors. So he's asking which of the following is an ionotropic receptors? Majority of them are metabotropic receptors. Some of them are ionotropic receptors. For example, 5-HT3 receptors, GABA receptors like GABA receptors and glutamate receptors, NMDA, AMPA, and kinase receptors. In nicotinic NN receptors, all of these are ionotropic receptors, but majority of them are metabotropic receptors, which are G protein coupled receptors and receptor tyrosine kinase associated receptors. So, he's asking which of the following will be an ionotropic receptor. So, 5-HT3 serotonin receptor is an ionotropic receptor. A 65-year-old post-menopausal woman presents with a history of multiple fragility fractures. She has been previously treated for osteoporosis, but she continues to experience bone loss. Which of the following medication would be most appropriate to stimulate the bone formation in this patient? He's asking which of the following can actually increase the activity of the osteoblast. So, teriparatide, which is actually a recombinant parathyroid hormone, the one which will actually increase the activity of the osteoblast. So, teriparatide is the answer. Denosumab is actually a monoclonal antibody which is directed against the rank ligand. So, it will decrease the activity of the osteoblast. Even bisphosphonates also decreases the activity of the osteoblast. So, he's asking which of the following will stimulate the bone formation, means which will increase the activity of osteoblast. So, teriparatide, recombinant parathyroid hormone, is the one which will actually increase the activity of the osteoblast. Which of the following class of oral hypoglycemic drugs works by closing the potassium channels in the pancreatic beta cells to increase the release of the insulin secretions? Potassium channel closures. They are nothing but sulfonylureas. Glipizide, and glibenclamide. Glimepiride. All of these, they are sulfonylurea drugs, which actually causes a closure of these potassium channels, and they will actually increase the intracellular potassium, resulting in the depolarization and opening of the calcium channels, entry of the calcium, release of the insulin. So, they actually carry a risk of hypoglycemia, sulfonylureas. So, he's asking which of the following class of oral hypoglycemic agents works by closing the potassium channels in the pancreatic beta cells to increase the insulin secretion. So, the answer will be glimepirides. Canagliflozins. Gliflozins are SGLT2 inhibitors. Gliptins are DPP4 inhibitors. Rosiglitazone is a thiazolidinediones. They are PPAR activators. Okay. Next. At approximately what gestational age is the development of the placenta generally completed? This is again another factual question. We just have to remember the almost development of the placenta is generally completed by 12 weeks. Just a factual question. Next. A 32-year-old pregnant woman at 28 weeks of gestation presents with shortness of breath, fatigue, and occasional palpitations. She has a history of rheumatic heart disease with mitral valve stenosis. On examination, she has tachycardia and an elevated jugular venous pressure, and an echo shows a mitral valve area of 1.8 centimeters, and there is also left atrial enlargement, and there is pulmonary hypertension. What is the most appropriate initial management for this patient? So, doing an immediate balloon valvuloplasty in a pregnant woman will be too aggressive. So, we will not actually choose immediate balloon valvuloplasty. Limited physical activity, dietary sodium, and beta blocker therapy. This will actually constitute the initial management for this patient with MS of mitral valve area of 1.8 centimeters. Intravenous furosemide and initiation of digoxin. This is not an appropriate initial management for this pregnant lady. Initiation of the anticoagulation therapy for warfarin. This is not actually an indication to initiate warfarin. So we will not be doing this. So the most appropriate initial management for this patient will be limited physical activity, dietary sodium, and beta blocker therapy. Next, which of the following is being demonstrated in the given image? What is he doing is, he's applying pressure over the skin. So lateral pressure over the skin, and the epithelium is actually getting peeled off. This is actually called as Nikolsky sign. There are two different signs. There are two: true Nikolsky, pseudo Nikolsky sign. True Nikolsky sign is due to acantholysis. Whereas pseudo Nikolsky, it is due to keratinocyte necrosis. The conditions where we actually find true acantholysis is pemphigus vulgaris, pemphigus foliaceus, and staphylococcal scalded skin syndrome. Whereas pseudo-Nikolsky sign, we actually see them in Steven-Johnson syndrome and toxic epidermal necrolysis. There will be pseudo-Nikolsky sign. Which of the following is being demonstrated? He is actually demonstrating Nikolsky sign. Bulla spread sign, they are actually seen with this pemphigus vulgaris. They will actually apply pressure over the bulla. After applying lateral pressure over bulla, the contour will be changed either in an angular form or a similar rounded form. Next, Auspit sign. Auspit sign is actually demonstrated in psoriasis. This is also called as Gratas test. We'll take a glass slide and we'll keep on garroting the lesions. So first there will be accentuation of the scaly plaques. And later we'll get the membrane. And at the end we will have some pinpoint hemorrhages. These pinpoint hemorrhages are occurring because in psoriasis, in histopathology, there will be suprapapillary thinning and there will be dilatation of the blood vessels. These dilated blood vessels are the one which will appear like a pinpoint hemorrhage in this Auspit sign. Next, Kovner's phenomenon. Kovner's phenomenon is also called as isomorphic response. There are two things, true cognate or pseudocognate. Pseudocognate is occurring because of the auto-inoculation, like viral ones. Whereas true cognate is the immune-mediated form. We can actually see that in vitiligo, psoriasis, and also lichen planus. Okay. A 36-year-old gravida 3 para 2 woman undergoes cesarean delivery and develops severe postpartum hemorrhage 4 hours later, that is unresponsive to uterine massage and uterotonic agents. She is tachycardic and hypotensive. To preserve fertility and avoid hysterectomy, the surgical team performs bilateral internal iliac artery ligation. What is the appropriate principle behind this procedure? To apply direct pressure on the bleeding sites, that will be tamponade. Or that could be some form of sutures, directly applying pressure on the bleeding sites. To reduce the distal blood flow and convert an arterial pressure to the venous pressure site. Yes, this is actually the principle behind the internal iliac artery ligation. To increase the uterine contractility and reduce the bleeding, it's actually function of uterotonics. This is not a reason why we do bilateral internal artery ligation to promote rapid healing of the uterine tissues. No. So the answer is to reduce the distal blood flow and convert the arterial pressure into the venous pressure slide. A 28-year-old woman presents to the emergency department with sudden onset of severe lower abdominal pain, dizziness, and shoulder tip pain. She has had amenorrhea for 7 weeks and a post-pregnancy test. On examination, she is pale with a blood pressure of 90 by 60 mm of Hg and a heart rate of 120 beats per minute. Which of the following diagnostic finding is most indicative of a ruptured ectopic? He's telling, he's asked which of the following is an indicator of a ruptured ectopic. Elevated serum HCG levels? No, it doesn't indicate that it is a ruptured ectopic. The presence of gestational sac in the uterine cavity just tells it's an ectopic. It doesn't tell whether it is ruptured or unruptured ectopic. The presence of free fluid in the abdomen on the ultrasound indicates that it's a ruptured ectopic. Absence of adnexal mass and pelvic examination doesn't tell it's a ruptured ectopic. The presence of free fluid in the abdomen in the ultrasound is indicative that it is a ruptured ectopic. A 72-year-old woman with a history of atrial fibrillation and a recent deep vein thrombosis is admitted to the hospital. Physician decides to initiate anticoagulation therapy with warfarin to prevent further thromboembolic event. Which of the following best describes the mechanism of action of warfarin? Warfarin actually inhibits formation of active forms of 2, 7, 9, 10. So, the inactive forms of 2, 7, 9, 10, if you get activated whenever they get carboxylate, gamma glutamide carboxylase. Converts this inactive 2, 7, 9, 10 into active forms. For this, it needs vitamin K in reduced form. So, vitamin K in oxidized form will be converted into reduced form by vitamin K reductase, epoxy reductase. Warfarin will inhibit this. So, there will not be any active form of vitamin K. So, whenever there is no active form of vitamin K, this conversion will not happen. This inactive form of 2719 will not get converted into active form of 2719. So, active form of 2719 are not present, so anticoagulation will be got. So, this warfarin will actually inhibit this vitamin K reductase. So, what is the mechanism of action of warfarin? It inhibits the synthesis of fibrinogen. No. It inhibits the platelet aggregation. No. It inhibits the synthesis of vitamin K dependent clotting factors. Yes. Directly binds and inactivates the thrombin. No, this is not the answer. So, the mechanism of action of warfarin is it inhibits the activation of vitamin K dependent clotting factors. It is inhibition of the activation of vitamin K dependent clotting factors. In red blood cells under low energy states, which of the following best describes the fate of pyruvate? In red blood cells do not have any mitochondria. So whatever glycolysis happens, every time it has to enter into lactic cycle, lactic acid, lactate dehydrogenase. So converted to acetyl-CoA to enter the citric acid cycle? No. Citric acid cycle will actually occur in the mitochondria. Because RBCs do not have a mitochondria, how can they perform a citric acid cycle? So this cannot be answered. Converted to oxaloacetate to replenish the citric acid cycle? Again, no. Because it doesn't have a mitochondria, from where it will perform a citric acid cycle? It will not be converted into oxaloacetate. Converted to lactate by lactate dehydrogenase to regenerate the NADP? Yes. Because to ensure that there is an uninterrupted glycolysis happening, for that to happen, it needs NAD plus. To ensure that NAD plus is regenerated, this lactate dehydrogenase will convert the end form of pyruvate into lactate, so that NAD plus will be regenerated and it can be utilized for the glycolysis part. So every time converted to lactate by lactate dehydrogenase to the NAD plus form. It is not converted to alanine via transamination. Because it doesn't have a mitochondria, it cannot participate in the citric acid cycle. A 32-year-old man presents with chronic abdominal pain, diarrhea, weight loss, and occasional blood in the stools. A colonoscopy reveals that there are skip lesions with areas of normal mucosa alternating with segments. Cobblestoning and deep linear fissuring ulcers in the patchy terminal part of the ileum as well as colon are observed. The histopathological findings from the affected areas are shown below. What histopathological features are observed in this patient's condition? He's telling, based on this itself, we can tell it's a Crohn's disease because occasional blood in the stools, okay? There are skip lesions and there are areas of normal mucosa alternating with the segments. That means characteristically he's telling that there is skip lesions and there is also cobblestoning and linear fissures. All of these are indicated that it's a Crohn's disease. So what is asking? Which of the following histopathological features on HPE what we will observe in this patient's condition? Presence of non-cacheating granulomas? Yes, we can observe that. Smooth transition between the ulcerated and the HCM normal mucosa? No, it's not a smooth transition. They will actually tend to have skip lesions. Absence of metaplastic changes in the epithelium? No. Both IBD forms, ulcerative colitis as well as Crohn's disease, they are pre-malignant. So they will have some malignant changes in the epithelium. Uniform distribution of the inflammation throughout the affected areas? No, they are not uniform. They will have skip lesions. So the answer will be option 1. They will have non-cacheating granulomas. A 32-year-old female is diagnosed with iron deficiency anemia, is prescribed oral iron supplements. Food containing which of the following can she take to increase the iron absorption? Iron absorption will be increased and decreased by something. It will be increased by the ascorbic acid, vitamin C, and also some amino acids. It will be decreased by phytates and tannins. He is asking which of the following can she take to increase the iron absorption? So you can ask, we can take either ascorbic acid or amino acid. So ascorbic. At which site does erythropoiesis primarily occur in an adult human? In an adult human, bone marrow of the long bones, yes. Bone marrow of all bones, no. Yolk sac in fetus. Liver in the early age, not now. So he is asking in the adult human. In adult human, only bone marrow of the long bones, there will be erythropoiesis, not in the all bones. A 62-year-old patient with severe COVID-19 pneumonia presents with acute respiratory distress syndrome (ARDS). After a few days of mechanical ventilation, the patient's ABG shows PaO2 of 58 mm of Hg and PF ratio of 120. Given the patient's condition, which of the following interventions should the team prioritize to improve the oxygenation? So first, ARDS, according to new Berlin criteria, it should be the onset should be within 7 days of the inciting trauma. And there should be bilateral infiltrates, bilateral chest infiltrates. And there should be non-cardiogenic pulmonary edema. And PaO2 by FiO2 ratio is less than 300 with a PEEP of more than or equal to 5 centimeters of water. So, if they fit in this, it will be ARDS. So, based on this PaO2 FiO2 ratio, P by F ratio, we can actually grade it. If it is less than 300 or less than 200 or less than 100. Less than 100 is severe, less than 200 is moderate, less than 300 is mild. So, the target that we have to achieve in ARDS is a PaO2 of 55 to 60 and an SpO2 of 88 to 96%. So, to improve oxygenation, we can actually increase speed. We can actually do proning 16 hours per day. We can actually properly sedate the patient and paralyze him. And we can actually give pulmonary vasodilators either in the form of inhalational nitric oxide or IV epoprostenol. And we should actually maintain the patient in a euvolemic state. So he is telling P by F ratio of 120 and PaO2 of 58 mm of Hg. That means we have actually achieved our target of PaO2 of 58%. But P by F ratio is 120. That means we are actually giving so much of fractional inspired of oxygenation to achieve this PaO2. That means despite adequate ventilator settings, the P by F ratio is still less than 150. That becomes a direct indication for proning. So here it is actually fitting. A P by F ratio of 120 and despite adequate ventilator settings, P by F ratio of less than 150 will directly become an indication for proning. So we have to implement proning in this position, proning in this patient. A 40-year-old man is undergoing a laparoscopic cholecystectomy under general anesthesia. During the procedure, he develops tachypnea, excessive sweating, tachycardia, and oxygen saturation of 92%. Anesthetist suspects a CO2 rebreathing due to an exhausted CO2 absorbent and replaces the soda lime canister. Which of the following inhalational anesthetic agent is safe to use with soda lime? So, we have to know 3 different compounds, how they actually react with the soda lime. First thing, trilene reacts with soda lime and it forms COSG. Sevoflurane forms compound E, whereas desflurane, isoflurane, N-fluorine, all of this reacts with soda lime and they form carbon monoxide. So he is asking which of the following is safe to use with soda lime. Let us see this. Desflurane. Desflurane, whenever reacted with soda lime, it is producing carbon monoxide. So it is not safe. Sevoflurane, whenever it is reacting with soda lime, it is producing compound A. Again, it is not safe. When trilene is reacting with soda lime, if it is producing phosgene, so this is also not safe. So the safer one will be halothane. Halothane do not actually react with soda lime, so that will be a safer option to use. Next, which of the following anesthetic agents should be avoided in patients who is undergoing a neurosurgery who are at risk of developing pneumocephalus? That means air in the cranial cavity. That means there is a risk that he might develop a pneumocephalus. So whatever is the gaseous anesthetic agent that might get diffused into the cranium, so we have to avoid all those. Let us look. Which of the following anesthetic agents should be avoided? Propofol is not a gas. Nitrous oxide is a gas, so there is a risk of getting diffused into the cranium, and there might be a risk of developing pneumocephalus. So we have to avoid this. Fentanyl is not a inhaler. Fentanyl is not a gaseous form. Mannitol is not a gaseous form. So nitrous oxide should be avoided in this patient because there is a risk of developing pneumocephalus because nitrous oxide can actually get diffused into the cranium. Next, a 45-year-old male presents with a slowly enlarging, painless neck mass near the angle of the mandible, and the angiogram of the neck shows the image below. What is this sign known as? Firstly, this is actually a common carotid and internal carotid and external carotid arteries. The tumor is this one. This is the tumor. This is actually a carotid body tumor. Because there is actually a big carotid body tumor, normally internal carotid artery and external carotid artery, they won't be separated so much. But because there is now a carotid body tumor here, they are getting separated like this. Lyre is actually a musical instrument. It looks very much similar like this. So this is a big carotid body tumor. Because of the presence of this carotid body tumor, it is appearing like a lyre. So what is this sign known as? Flip sign, dot sign, steeple sign, lyre sign. It is called as lyre sign. Then what is flip sign? Flip sign is actually seen in glomus jugular tumor, which is nothing but erosion of the carotico-jugular spine. Whereas dot sign is also known as crescent sign. That is, in the posterior wall of the pharynx, if at all the mass is an anthropoidal polyp, on an X-ray we will actually have this air, crescent of air. If at all we do not have a crescent of air and we actually see a mass, that could be adenoid. So if there is a crescent sign or a dot sign, it indicates that the mass is an anthropoidal polyp. If there is no dot sign or crescent sign, it indicates that it is an adenoid mass. Steeple sign is nothing but steepling. It is actually seen in group, acute laryngotracheobronchitis. Next, a 45-year-old old patient presents with headaches and focal neurological deficits. MRI of the brain reveals a diffusely infiltrating tumor in the cerebral hemisphere. Histopathology shows a low cellularity infiltrating glioma with a mild nuclear atypia without a necrosis or a microvascular proliferation, which is following is the most likely diagnosis. This we have to know something called as AMEN of the brain tumors. A means atypia, M is mitosis, E is endothelial proliferation, N is necrosis. So based on these four features, we actually divide brain tumors into grade 1, grade 2, grade 3 and grade 4 tumors. Grade 1, nothing of AMEN will be present. Grade 2, only atypia will be present. Grade 3, atypia and mitosis will be present. more than or equal to 3 of AMEN if they are present, it will be grade 4 tumors. So we have to know the examples of grade 1, grade 2, grade 3 and grade 4 tumors. The examples of grade 1 tumors is juvenile pilocytic astrocytoma and SEGA, subependymal giant cell astrocytoma, which is actually seen with tuberous sclerosis. Next, grade 2 tumors are pylomyxoid xanthoastrocytoma, diffuse astrocytoma, fibrillary astrocytoma. That is grade 2. Grade 3 is anaplastic astrocytoma. Grade 4 is glioblastoma. So he is telling there is mild nuclear atypia and there is no necrosis or there is no vascular proliferation. That means there is only atypia. That means they belong to grade 2. That means which of the following is a grade 2 brain tumor? Pilocytic astrocytoma is a grade 1 tumor. Diffuse astrocytoma is actually grade 2 tumor. Anaplastic astrocytoma is a grade 3 tumor. Glioblastoma multiforme is a grade 4 tumor. Because he is telling there is only mild nuclear atypia and there is no necrosis and there is no microvascular proliferation as well. They will actually fall into grade 2. That means diffuse astrocytoma will be answer for this question. A 7-year-old child presents with morning headaches, nausea, vomiting, and vertigo. Neuroimaging reveals a tumor which is arising from the fourth ventricle. Which of the following is the investigation of choice for evaluating this lesion? Here he is telling it's a fourth ventricle. That means it's a posterior cranial fossa tumor and it's also an infratentorial tumor. Infratentorial tumors, all of them, they will be better visualized on an MRI. And also, if it is a tumor, we actually need a clear demarcation whether there are surrounding tissue involvement or not. So MRI will actually give us a better view of those involvement. So investigation of choice for evaluating this lesion would be an MRI. Because even the posterior cranial fossa tumors and infratentorial tumors will be better visualized on MRI. A 62-year-old woman presents with a recurrent adenoid cystic carcinoma of the submandibular gland. The tumor has been surgically resected twice previously and both pathology reports demonstrate that there is a perineural invasion. Which of the following is the most appropriate next step in the management? Here he is telling a pathology report says both times there is actually a perineural invasion. So what are we going to do? What is the approach? How we will deal with the parotid gland tumor? So there are two modalities. Either we do surgery or either we do radiotherapy. Surgery, if it's a low grade tumor, it's a high grade tumor. If it is a low grade tumor, no, we will actually proceed with total conservative parotidectomy. If it is a high grade tumor, we will actually do a radical parotidectomy. The difference between these two is, in radical parotidectomy, we will actually remove the facial nerve as well. Facial nerve and ipsilateral masseter will be removed. And this facial nerve will actually be grafted with the greater auricular nerve or a sural nerve. So the indication for this radiotherapy becomes if there are positive lymph nodes or if there is a lymphovascular invasion or if the size of the tumor is greater than 4 centimeters or if there is a perineural invasion. What is he telling? A 62-year-old is having a high-grade tumor, okay, of the submandibular gland, has been surgically resected twice previously, and both of them, they demonstrate that there is a perineural invasion. What is the most appropriate next step in the management? Because there is a perineural invasion, we will do a radiation therapy for this patient. Next, a 4-year-old child presents with recurrent prolonged seizures and developmental delays. Genetic testing reveals a mutation in the SCN1A gene. Based on these genetic findings and the clinical presentation, which of the following is the most likely associated? West syndrome? No. SCN1A is actually associated with Dravet syndrome. There are few genetic mutations which are associated with seizures. One is SCN1A associated with Dravet syndrome. Another one is CSTB mutation, which is associated with Unverricht-Lundbaum syndrome. Another one is EPM2A mutation, which is associated with Lofora syndrome. These three genetic mutations are actually associated with seizures. So he is telling that there is a SCN1A gene mutation. So it is actually associated with Dravet syndrome. Next, a 2-day-old neonate develops acute hypernatremia. Sudden shrinkage of the brain cells due to the hyperosmolar state is most likely to result in which of the following complications? Acute hypernatremia, the neonate has developed acute hypernatremia and the brain cells started to shrink because of the hyperosmolar state. So what is going to happen? Paralytic illness, something is got related with the potassium, low potassium levels. So if this cannot be. Tachyarrhythmias, again something related to the potassium metabolism. Osmotic demyelination syndrome, this is related to low levels of sodium. A rapid correction of hyponatremia is associated with central pontine demyelination syndrome or osmotic demyelination syndrome. This, it will be an intraparenchymal hemorrhage because whenever there is shrinkage of the brain, the bridging veins will actually get a shear stress on them because of the shrinkage. That can actually result in a bleeding. So, acute hypernatremia resulting in the shrinkage of the brain cells because of the hyperosmolar state can actually create a stress on the blood vessels and that can result in the intraparenchymal hemorrhage. So, this will be answered. By ruling out these remaining three options, we can actually get into this intraparenchymal hemorrhage. A 25-year-old woman presents with fatigue, joint pain, and photosensitive rash. She reports mouth ulcers and hair loss. Laboratory tests shows positive ANA and elevated double-stranded DNA antibodies. Further examination reveals that there are elevated levels of interferon alpha. Which of the following is a consequence of elevated interferon alpha in this condition? She is having antibodies. So, what is the consequence of having elevated levels of interferon alpha in this condition? Decreased B cell activation? No, decreased. In fact, there will be increased B cell activation resulting in the formation of more amount of antibodies. Enhanced clearance of the apoptotic cells. Had there been an enhanced clearance of apoptotic cells, there will not be an autoimmunity because there is a defective clearance of the apoptotic bodies. There is autoimmunity resulting in cessation. So this cannot be this. Suppression of the T cell activity. No, there will be an increased T cell activity. Because of this elevated interferon alpha, there is increased antibody production resulting in all these manifestations. So this is the answer. Next. A 25-year-old female presents with severe fatigue. There is also sore throat and swollen lymph nodes for the past week. Noticing a similar illness in her partner. Examination shows there is a low-grade fever, mild hepatosplenomegaly, cervical lymphadenopathy. As a complete blood count indicates absolute lymphocytes with atypical lymphocytes. This is actually telling that it is an infectious mononucleosis. What is the most likely diagnosis? Infectious mononucleosis is not there in the option. That means we have to know the other name of infectious mononucleus, which is also known as glandular fever or Cushing's disease. These atypical lymphocytes are called as downy cells. Okay, it's just that we have to know other name of infectious mononucleus as glandular fever. That's it. Next, a 50-year-old man presents with persistent fatigue, chest pain, and difficulty in breathing. He grew up in a rural northern Argentina where a childhood bug bite caused left eye swelling. Examination reveals leg swelling, S3 gallo, fatigue. IgG antibodies to trypanosoma cruzi are detected by ELISA. Which of the following statements are true regarding this condition? That means he has now an infection of trypanosoma cruzi. Cardiac manifestations are seen only in 30% with chronic form of disease. Maybe yes or no. Benzonidazole is considered as a drug of choice for the chronic form of the disease. Yes, it's right. Chronic form of the disease has cardiac and gastrointestinal involvement. Definitely yes. And peripheral blood microscopy can be used to diagnose a chronic disease. Peripheral blood microscopy cannot be actually used to diagnose a chronic disease. No. The acute form of disease presents with generalized rash. Actually, acute form of disease, they will actually have a chagoma and Romanas sign, which is nothing but a big mass in the eyelid, resulting in the drooping of the eyelid. So, yeah, chronic forms of the disease can actually have this gastric and cardiac involvement in the form of megacolon, megaesophagus, and also in the form of echalacia. So, this has to be present. Acute form of the disease actually presents with chagoma and Romanas sign. So, 5 should not be present. This cannot be. So, the answer will be option 1. Next. A 38-year-old patient presents for an eye examination. During the duochrome test, the patient reports that they can see the red lights more clearer than the greener lights. What is the most likely refractive error for this patient? If I were you, I would have definitely left out the question. I don't know this question, but let's see. He's telling he's able to see red lights more better than the green lights. Red light is actually having a longer wavelength. And green light, compared to the red light, green light has actually shorter wavelength. Because there is a longer wavelength, there will be less refraction. And the waves will actually travel very far. Because there is shorter wavelength, there will be more refraction. And the waves will actually travel for a shorter distance. So now let's see. He is able to see red lights more clearer than the green lights. That means in his eye, the red lights are actually falling in a correct position. And a green light is actually falling more front. Green light is actually falling more in the front. That means previously he is actually having myopia. Because he is having myopia, in myopia what happens? The wave which is coming, it will actually fall in the front. So now, because red wave is coming, red wave is actually traveling for a greater distance. Is traveling for a greater distance and is actually falling in a correct location. That is the reason why he is actually able to That is the reason why he is actually able to see the red waves correctly instead of the green waves. Green waves will actually fall even front. Myopia. Had that been a hyperopia, in hyperopia, the waves will actually fall behind. Here, red waves will fall even further behind, whereas the green waves will actually form correctly. So this is actually a myopic eye. And this is a hyperopic eye. So in a myopic eye, because the red waves travel for a longer distance because of the lesser refraction and the longer wavelength, red lights will actually fall on a correct location. So they will be able to see red lights better. Whereas in hyperopia, the green lights will actually fall on the correct location. So a hyperopic eye will actually see a green lights better. So he's telling red lights are more clearly visible than the green lights. So the answer for this question will be myopia, because in a myopia, the red light will actually fall on a correct location. So they will be able to see red lights much better than the green lights. This is a normal eye. Okay. Next. A 40-year-old woman presents with a 3-day history of painful vision loss in her right eye. She has a history of multiple sclerosis. Yeah, on examination, her visual acuity is 20/30 in the right eye, and the relative apparent pupillary defect is noted. The moment we see RFAD, we can think the problem is with the optic nerve. She reports difficulty in distinguishing the red and the green colors in the right eye, while color vision is normal in the left eye. Which of the following is the most likely cause of her acquired color blindness? So, in a setting of multiple sclerosis, involvement of the optic nerve, and a painful vision loss, something has to strike to our mind. That is optic neuritis. It is actually fitting. A painful vision loss in a setting of multiple sclerosis and the presence of RFAD, making it more in favor of optic nerve pathology. So, optic neuritis is the answer. A 22-year-old woman presents with a history of unstable interpersonal relationships, intense fear of getting abandoned, chronic feelings of emptiness, and recurrent suicidal gestures. When she is under severe emotional distress, her family reports that she sometimes experiences brief period of severe paranoia and depersonalization lasting for few hours. These transient reality testing disturbances are most characteristics of which of the following personality? The keywords that we should highlight here is unstable interpersonal relationships, and also there are recurrent suicidal gestures. So both of them are actually features of borderline personality disorders. So the borderline personality disorders is fitting. Narcissistic theories, they are more self-loving. They want to get praised because of them. Histrionic PD, they are actually attention seekers. They are drama makers. Attention seeking behavior will be present for them. Paranoid, they are suspicious of everyone. They do not trust in anyone. This is about this borderline personality disorder. Which of the following disorders are classified under the somatic symptom and the related disorder? Somatic symptom and related disorder. Somatic symptom disorder will come under the functional neurological symptom disorder will come under the dissociative amnesia is not a somatic symptom disorder. That is entirely different group of disorders. So 4 should not be present. All of the above cannot be the answer. And next, factitious disorder is also a somatic symptom disorder. So the answer for this question will be option number 2. Next, a patient with rectal adenocarcinoma is being evaluated for sphincter preserving surgery. Which of the following tumors is best suited for management by the transanal local excision? So, there is anal verge. If the tumor is beyond the 5 centimeters of anal verge, or if it is less than 5 centimeters of anal verge. If it is beyond 5 centimeters of anal verge, we can safely perform a sphincter preserving surgery. If it is less than 5 centimeters, we cannot actually perform a sphincter preserving surgery. And for this, the surgical margins will be, if there is a tumor, the proximal margin should be 5 centimeters and the distal margin has to be 2 centimeters. So based on this, he wants to perform a sphincter preserving surgery and a transanal local excision. Look at this. It is a T2N0 tumor of 5 centimeters from the anal verge. Okay. T1N0, it's a well differentiated tumor and 6 centimeters from the anal verge and the size is less. Okay, this is actually fitting more because it is more than 5 centimeters and it's a well differentiated tumor and it is confined to the mucosa and the size is also less. A T3N0 tumor 10 centimeters from the anal verge. The centimeters from the anal verge is actually fitting, but T3 involvement of the muscularis, how can we do a transanal local excision? We cannot actually perform a complete total anal transanal local excision for a T3 tumor. And a T1N1 tumor with 4 centimeters from the anal verge. 4 centimeters from the anal verge is less than 5 centimeters, so we cannot actually perform a sphincter preserving surgery. So, the better option to go for is a T1N0, a well differentiated tumor, which is 6 centimeters from the anal verge and a size of less than 3 centimeters in size. Next, a pharmacology student is studying how receptors respond to long-term exposure to high levels of an agonist. Which of the following does not contribute to the down-regulation of the receptors? Whenever there is a higher levels of action or higher levels of ligands coming to the receptors get down-regulated in many of the ways. First thing, either they can get internalized. Whatever the receptors are present, they will actually go into the cell. Or the receptors can actually get downgraded. Or there can be reduced protein synthesis, reduced synthesis of the receptors itself. All of this can actually result in down regulation of the receptors. He is asking which of the following do not contribute to the down regulation of the receptors. Lower levels of the stimulating hormone. If there are higher levels of stimulating hormone, receptor down regulation will happen. If there are low levels of stimulating hormone, in fact, increased levels of receptor signal, receptor production will be present. Receptor internalization can result in down regulation. Reduced protein synthesis, again receptor down regulation. Receptor desensitization, again receptor down regulation. So this do not actually contribute to receptor down regulation. This actually upregulates the receptors. Low levels of stimulating hormone will actually upregulate the receptors. So the answer will be option 1. Next. Which of the following autoantibodies is least likely to cause a homogeneous nuclear staining pattern on the immunofluorescence? So first, let us look at the homogeneous pattern. Speckle, nucleolar, and centromere. Homogeneous, entire cell, entire nucleus will be homogeneously green. nucleolar, inside the nuclear, only a small dot, only a targeted something which is targeted inside the nucleus, only that is getting an antibody, so a small dot. The centromere, because the centromeres are actually in a line like, we can actually have like this, like chromosomes. We do not actually see a chromosome, only centromeric antibodies. So we will actually see something like this. Every centromere arranged in the form of a linear pattern. Like speckled pattern, something which is not homogeneous, not nuclear, not centromeric, will be a speckled pattern. So these are the patterns of immunofluorescence. Homogeneous, they are homogeneous because against everything in the nucleus, there are antibodies. So against chromatin, against histones, in the nucleolar pattern, against the RNA, there is antibodies. Here against the anticentromeres. This speckled pattern, it is non-specific. It can be present for anything, mostly anti-Rho, anti-La can be present. So he is asking, which of the following autoantibodies is least likely to cause a homogeneous nuclear staining? Antihistone antibodies, definitely yes. Can cause a homogeneous pattern. Anti-chromatin antibodies, definitely yes. Anti-double stranded DNA antibodies can also form homogeneous pattern. It can actually form a peripheral rim pattern as well. Only a peripheral rim. It can form both the homogeneous pattern as well as the peripheral rim pattern. So anti-RNA antibodies, it will have a nucleolar pattern. So this will be answer purpose. Next, which of the following bariatric procedure is a reversible procedure? Laparoscopic gastric banding, laparoscopic Roux-en-Y gastric bypass, sleeves gastrectomy, laparoscopic biliopancreatic diversion. All of these are major surgical procedures. Roux-en-Y gastric bypass, laparoscopic sleeve gastrectomy, a part of the stomach has been removed. Biliopancreatic diversion, all of these are irreversible surgical procedures, whereas laparoscopic gastric banding is a reversible procedure. So this is an answer. During your rotation in pediatric endocrinology, you evaluate a 8.5-year-old girl with early onset of the breast development. Her parents are concerned about premature puberty. Precocious puberty in girls is defined as appearance of secondary sexual characters before which age. There are in females, in males. Precocious puberty, delayed puberty. Precocious puberty, if below 8 years of age, if any secondary sexual characters are coming in female, it is called as precocious puberty. Before 9 years of age, any secondary sexual characters coming in male are called as precocious puberty. Delayed puberty in females, without any secondary sexual characters or without any secondary sexual characters till 13 years, or with not attainment of menarche by 15 years of age. 13 means no secondary sexual characters and no menarche. Here there might be secondary sexual characters, but still there is no menarche. If both are not present, 13 years. If one is present, like secondary sexual characters are present, by the age of 15, if she doesn't get menarche, it is called as delayed puberty. So he is asking, precocious puberty in girls is defined as the appearance of secondary sexual characters before what age? It is before 8 years of age. A newborn is noted to have cataracts. The mother recalls experiencing a febrile rash during the first trimester of pregnancy. On cardiac examination, a continuous machinery murmur is auscultated. Continuous machinery murmur indicative of patent ductus arteriosus. So here, if they are also showing cataracts, so everything is actually fitting into congenital rubella syndrome. So, which cardiac lesion is most commonly responsible for this murmur? Continuous machinery murmur is actually seen with patent ductus arteriosus. Yeah, in the congenital rubella syndrome, you will actually have cardiac manifestations, eye manifestations, and ear manifestations. Cardiac manifestations in the form of patent ductus arteriosus, eyes in the form of cataracts, ears in the form of sensory neural hearing loss. A 5-year-old child with a history of restricted diet presents with painful limb swelling and periauricular hemorrhages. Radiographic evaluation of knee reveals a prominent frenkel line. Which of the following best describes the pathological basis of this disease? What is this? It's a painful limb swelling and perifollicular hemorrhages. And radiography is actually revealing a frenkel line. All of these are actually suggestive of scurvy changes. So he is asking what is the basis of pathological basis of development of this frenkel line? Formation of a lateral metaphyseal bony spur. That is actually pelican spur. It is not frenkel line. Next, calcification of cartilage at the metaphyseal region. That is what is frenkel line. Radiolucent band at the metaphysis. That is Trummerfeld zone of scorbutic. Trummerfeld scorbutic zone. Ring-like opacity around the epiphyseal ossification center. This is Wimberger's ring sign. He is asking what is the pathological basis of the frenkel line. It is nothing but calcification of cartilage at the metaphyseal region. Nose pickers carcinoma is a term commonly used to describe which of the following conditions. Nose pickers carcinoma, you just have to know other name of the nose picker carcinoma, which is squamous cell carcinoma. That's it. Inverted papilloma is also called a Schneiderian's tumor. Ringer's tumor or Schneiderian's tumor. Schneiderian papilloma. A new diagnostic test for a disease Y is compared with the gold standard investigation. Out of 120 individuals confirmed to have the disease, that means totally diseased are 120. The test correctly identifies 96. That means truly positive are 96. What is the sensitivity? Sensitivity is true positive upon true positive. Had that been false positive, that will be positive predictive value. So we have to take falsely negative. So what is this? True positive plus false negative means totally diseased. So true positive is 96, totally diseased is 120. So if we calculate this, we get something 80%. So 80% is the sensitivity of the test. A patient is undergoing emergency resuscitation is being ventilated using the technique demonstrated in the attached video. Which of the following findings is most reliable indicator that the bag and mask ventilation is being performed effectively? Bilateral chest raise with each of the ventilation. Yes. Visible abdominal distension. Visible abdominal distension tells that the air is actually going into abdomen rather than into the lungs. Oxygen saturation of the 100%. Oxygen saturation of the 100% is not indicated that the bag and mask ventilation is being performed effectively. EtCO2 greater than 60% indicates that the bag and mask ventilation is not effective, and we actually have to improve the bag and mask ventilation. So bilateral chest raise with each ventilation is indicative that the bag and mask ventilation is effective. A 30-year-old woman reports gradually worsening hearing in her left ear over the past several months. The bedside examination demonstrated in the attached video is performed using a tuning fork placed over the midline of the forehead. She reports hearing the sounds more prominently in the right ear. Rennie's shows air conduction is greater than bone conduction in both ears. That means right ear is either normal or right ear is actually having a sensory neural hearing loss, or left ear is normal or left ear is having a sensory neural hearing loss based on the Rennie's test. In both ears. Whereas when performed Weber's, she reports hearing the sound more prominently in the right ear. That means Weber's is localized to the right ear. What does that indicate? Either left ear is having a sensory neural hearing loss or a right ear is having a conductive hearing loss. Based on Rennie's, there is no possibility that the right ear can have a conductive hearing loss. So this cannot be. But based on Rennie's, there is a possibility that the left ear is actually having a sensory neural hearing loss. So likely she might be having a left ear sensory neural hearing loss. Next. A 60-year-old man complains of progressive unsteadiness while walking for the past few months. During neurological examinations, the test demonstrated in the attached video is performed. He is able to maintain his balance with his eyes open, but begins to sway and lose stability when his eyes are closed. The finding is most suggestive of dysfunction involving which of the following. So, here, whenever the eyes are open, he is able to stand still. But whenever his eyes are actually closed, he sways. That means whenever the eyes are open, the visual response, the visual information is actually supplementing this proprioception. Normally, whenever the eyes are closed, we do not sway because our proprioception is intact. But here in this patient, when the eyes are closed, he is swaying. That means his proprioception is gone. But whenever his eyes are open, despite the proprioception being abnormal, his visual response is actually compensating for his proprioception. That is the reason why he is able to stand. But whenever he is closed with his eyes, visual information won't be going. So whatever the proprioception is lost, so he will be swaying. So this proprioception will be carried by which column he is asking. So which of the following dysfunction is most likely it is suggestive of. So the proprioception from the legs will be carried by the dorsal column pathway of the spinal cord. A 45-year-old presents with a gradually progressive difficulty in climbing stairs, getting up from a low chair and rising from the floor over the past 6 months. During gait assessment, the walking pattern demonstrated in the attached video is observed. The gait abnormality is most likely due to weakness of which of the following muscle groups. Even if we do not see the video, from the question he is telling there is difficulty in climbing stairs and is also difficulty in getting up from a chair and also from the floor. That means he is having difficulty in using the proximal muscles. Proximal muscle groups are the problem. So by this we can tell that the proximal girdle muscles are the one which has got the problem. That is the reason why he is having even a gait abnormality. If there is a distal limb weakness, he would have difficulty in wearing a chappal. But because he's having proximal muscle weakness, he is having difficulty in getting up from a chair, climbing up stairs. A 60-year-old man presents with progressive abdominal distension, shifting dullness, and suspected ascites undergoes the procedure demonstrated in the attached video for diagnostic fluid aspiration. Which of the following laboratory parameters is most valuable for distinguishing ascitic due to portal hypertension from ascitic due to other? This is a SAG ratio, which is serum, ascitic, albumin, gradient. If the SAG is greater than 1.1, it tells it is a portal hypertension. If the SAG is less than 1.1, it says it is not due to portal hypertension. After this, we have to see ascitic fluid total protein. If the ascitic fluid total protein is less than 2.5, that means the liver is not able to produce. That means it will be a cirrhosis. That means sinusoidal cause. The liver is not able to produce enough amount of protein. That is the reason why we do not actually see ascitic fluid protein as well. But if at all, if the ascitic fluid is less than 2.5, but the SAG is less, but the SAG is also less than 1.1, that means it is a nephrotic syndrome. Whereas what if the ascitic fluid protein is greater than 2.5? If the ascitic fluid is greater than 2.5, it indicates either it is a pre-sinusoidal or a post-sinusoidal obstruction. Provided the SAG is greater than 1.1. If at all the ascitic fluid is greater than 2.5, but still the SAG is less than 1.1 means that could be due to malignancies, some pancreatitis, or some tuberculosis. So this is actually how we approach based on the SAG ratio. So he is asking, which of the following is the most valuable for distinguishing ascites due to portal hypertension and from ascites due to other cause? All of this workup has actually started with the SAG ratio. So SAG, serum, ascites, albumin, gradient. A 24-year-old primary gravid at 39 weeks of gestation undergoes a routine abdominal examination during early labor. The obstetric manual demonstrated in the attached video is being performed. During examination, the examiner is unable to insinuate the fingers below the presenting part. This finding most likely indicates that the fetal head is. If at all, the examiner has insinuated her fingers below the head, it tells that the head is above the pelvic rim and it is not engaged. But here it is telling unable to insinuate the fingers below the presenting part. That means the head actually got into the pelvis and it got engaged. That is the reason why we were not able to insinuate our fingers below the head. So this finding is most likely indicative that the head is actually engaged. If there is no engagement, we would have approximated our fingers. Because now there is engagement here, the head has actually gone into the pelvis. So we were not able to insinuate our fingers below the head. Okay. Next. A full-term newborn is evaluated during a routine neurological examination. The reflex demonstrated in the attached video is elicited by touching the infant's lips. Persistence of this reflex beyond the normal development period is most strongly associated with dysfunction of which of the following? This is suckling reflex. The presence of primitive reflexes beyond a certain period of beyond the normal period of development is indicative early marker of cerebral palsy. He is telling a full-term newborn evaluated by routine neurological examination. The reflex that he is demonstrating is suckling reflex by touching the infant's lips. Persistence of this reflex beyond the normal development period is most likely suggestive with dysfunction of the frontal lobe or a cerebral palsy. Next. A 28-year-old woman presents with diffuse hair loss for the past 3 months following a febrile illness. During examination, a maneuver demonstrated in the attached video is performed and more than 6 hairs are easily extracted with gentle traction. The finding is most suggestive of which of the following conditions? It cannot be alopecia areata. It cannot be androgenetic alopecia. It cannot be trichotillomania. It is telogen effluvium because in the question it says following a febrile illness. So following a febrile illness, there can be a hair fall. That hair loss is actually called as telogen hair loss. And the test that he is demonstrating is hair pull test. Whenever we actually hold 50 to 60 hairs and we apply traction, continuous traction, and we get 10% of the hair out. If they come into the hand like 5 to 6 hairs, the test is considered positive. That means active hair shedding is going on. This is indicative of telogen effluvium. But if the question says following chemotherapy, there is a severe hair loss, that will be considered as anagen effluvium. In anagen, the hair follicles will be rapidly growing. So whenever chemotherapy is given, those rapidly growing hair follicles will actually suffer a loss. That is what is called as anagen effluvium. In alopecia areata, there will be antibodies directed against the pigmented hair follicles. So what happens is, in an area, let's say there are pigmented hairs and there is some white hair. Okay, let's say this is white hair. So what happens is, the antibodies will come and destroy all this. So there will be loss of black hair and there will be only white hair. This appears like as if going white overnight. This is what alopecia areata is. And the hair actually looks like an exclamatory mark. And on histopathological appearance, around the hair follicle bulb, there will be so many lymphocytes. There will be so many lymphocytes called as swarm of bee appearance. That is about alopecia areata. Next, trichotillomania, they will actually have perifollicular hemorrhages. Okay. A 34-year-old woman presents with progressive unsteadiness while walking and difficulty performing the fine hand movements. During neurological examination, she is asked to perform the maneuver demonstrated in the image given below. The clinical finding most likely indicate a lesion involving which of the following. Even if you do not see this video, he is telling there is progressive unsteadiness while walking and difficulty in performing the hand movements. That means she has got something problem with her balance. So the balance will be taken care by the cerebellum. So the problem is with the cerebellum. Next, a 65-year-old chronic smoker presents with progressive exertional dyspnea and chronic cough. During examination, the breathing pattern demonstrated in the attached video is observed. This maneuver primarily helps improve respiration by which of the following mechanisms? This is closing the lips and breathing, which is pursed breathing, pursed lip breathing. Whenever they do the pursed lip breathing, there will be opening, the smaller airways will still be kept open. Instead of collapsing. That is the reason why these people do pursed lip breathing. So he is asking by which of the following this maneuver primarily helps improve respiration by which of the following mechanisms? Increased pulmonary capillary perfusion? No. It prevents the premature collapse of the smaller airways during the expiration. Yes. Increase the surfactant production by the tighter pneumocytes. No. Stimulating the central respiratory center to increase the respiratory rate. Again, it's no. So the answer will be preventing premature collapse of the smaller airways during the expiration. A 10-year-old child presents with foul-smelling, greasy diarrhea, abdominal bloating, and weight loss after returning from a camping trip where untreated steam water was consumed. The motility pattern demonstrated by the organism in the attached video is observed on a freshwater spool wet mountain. The clinical manifestations are primarily due to which of the following mechanisms? Even if the video is not there, they are telling it's a foul smelling, greasy diarrhea, and there is abdominal bloating. That means there is steatoria. A parasite causing steatoria is Giardia lamblia. So he's asking the clinical manifestations are primarily due to which of the following mechanisms? Invasion and alteration of the colonic mucosa? No, that will be entamoeba histolytica. Malabsorption due to adherence of the trophozoites in the small intestine. Exactly. This is what Giardia does. Production of the enterotoxin causing secretory diarrhea? No, that is not a parasite. That is E. coli. Hematogenous dissemination to the liver forming an abscess. This is also not. He is telling about pyogenic liver abscess. So the answer will be malabsorption due to adherence of the trophozoites to the small intestinal mucosa. And this Giardia will actually show falling leaf motility. Next. Yeah, I think we have completed all the 180 questions. It's just last repeated, the questions have been repeated in the last slides. So I just wanted to tell, at this point of preparation, please do not question your preparation and please do not question your abilities. Whatever you have done till now is enough to crack the exam. You don't have to worry so much about your preparations. Just stay in the flow and just keep on revising whatever you have done till now. Just keep moving. Uh, Please maintain all your energy till the end, so that what happens is you can just revise fastly in the end and you can just go and crack the exam really good. Please, please have faith in your preparation and whatever the subjects that you have done, whatever the topics that you have read, only they will come. Be positive minded. Luck might favor you that day. You will definitely score good. All the best.